April Fool's agenda, so that's good. But welcome. Any declarations of interest? No. Okay. Thank you for that. Apologies. First of all, I think we should recognise that unfortunately Richard can't be here today for personal reasons, sad personal reasons. He'll be back in, I think, end of next week. But I've got apologies from him. I haven't received any other apologies, so I'm hoping all those are here. Okay, so thank you. Minutes of the meeting on the 4th of March. Any comments there on accuracy? No? Okay, I'll take those as an accurate record then. Matters arising. Shirley's just trying to sort out my other connection, so she's not here, so I'll deal with these. Most of those are green, which is great. A couple of those dates, the other two dates aren't yet come through, so we're on track with all the timescales of those. But does anyone want to raise any queries on those? Nope. Okay, thank you. On my report, just a few things. I mean, I think, yeah, it's a fantastic achievement that we've done as a trust, every single person here, in terms of, I think, two things particularly recently. One is the staff engagement, which was, you know, to see that continuing to improve and significantly improve, even when we're last year at a reasonably high level. I think that was really encouraging, and it gets tougher and tougher as you get higher and higher up the rankings. But to see the improvement we've seen is absolutely brilliant. So congratulations to all, and you know, all those who work here, as well as some of our other partners. Secondly, the Acute Trust of the Year. I just think, you know, if you think where this trust was, where it probably would have been 7, 8, 9 years ago, was right at the bottom end of the trust. Now to be the Acute and Specialist Trust of the Year is absolutely fantastic, and something we all need to, you know, be really proud of. But it's also an opportunity for us to kick on to how do we build from here during what will be quite a difficult year, I think, and we'll hear more of that later on. But, you know, if we can carry on building those, and, you know, okay, so we're the UK Trust of the Year this year, well, let's aim higher and be the European Provider of the Year next year. So I'm sure that we've got that ambition anyway, so that's really good. I'll come back to the fact that I've announced that I will be going on secondment to the Leicester Hospitals in a minute, and Claire Ward will be taking over as chair. I'll make a few comments on those. But the other things I just wanted to sort of highlight was the Hope Orchard, which wasn't just at the hospitals, it's much wider than that, with fruit trees being planted everywhere. And Helena Clements, who you all know, did some really good work in terms of coordinating that with a very small team. Richard has a picture of him holding an extremely big hammer over my head as he tries to knock in a steak, which he's very proudly showing to everyone. So when he's back, I'm sure he'll share that with you. But anyway, but no, I just think that was really good. And the other thing I wanted to highlight was the wider collaboration, particularly with HMP Landone Grange, which is absolutely, this is exactly the sort of thing that increasingly we need to be doing in terms of building relationships, not just with others in the NHS, but more widely, using local providers wherever possible, supporting local economic development, etc. That's all what the anchor institution is all about. And it was really nice to see that recognised by Ofsted. But perhaps I think more importantly, that's another example of how the impact that we can have is much wider than just delivering health, although that's still our core purpose. So those are the bits I just wanted to pull out of the report. I just want to say that, as you know, I've agreed to go to Leicester for a year to be their interim chair, and I just want to say thank you very much. It's been a real privilege over the last 4 years to have been part of the Sherwood journey. I feel a little bit like an imposter in that I've come in at the good part of it and didn't have to do all the heavy spade work right at the beginning, but that was just luck. But But it is, Sherwood is an amazing place to work. I think it's one of the friendliest hospitals I've worked in. It's one of the ones where there's real pride about working here, which is really good. And also it's very much integrated into the community in a way which some of the really big trusts aren't, and indeed it would be very difficult to be integrated in the same way. And those are things I think we need to hang on to. They are some of the contexts within which we work, and I think they do underpin the strategy looking forward to a considerable degree. I'd like to thank, therefore, all the staff who contributed and all those who contributed to our journey over the 8 to 10 years. And indeed, Richard and I had made a point of doing that. And there are some conversations being set up where NEDs, governors and staff can have a conversation initially offline, so that, you know, to help connect, I think, some of the NEDs and the governors back with the trust, and really understanding what the last years felt like to staff and others who work at the trust. So I think those sort of continuing to use avenues like that to facilitate the communications across the trust is really, really good. And also I'd like to just thank the board. I mean, I think I'm very lucky. I think this is one of the strongest boards and most cohesive boards I've worked on. And I've been a chair now for 10 years and prior to that in different roles. You know, it really is good. That doesn't mean that we've got everything right, and it doesn't mean that we shouldn't be modifying and changing our approach. And I'm sure that Claire will do some of that as she takes over. But I do think that it's, you know, this has been one of the most constructive, productive boards, and one of the most enjoyable, even though the last year has been remote. So thank you very much for all your support, for your challenges, for your asking questions, and for your ideas and time. So I'd like to thank the board, both non-execs and execs, for that input. And finally, I'd just like to say I think the next year under Claire is, yes, a difficult year, but one of huge opportunities, and it's a question of balancing that. And I'm sure that you know, Sherwood will go from strength to strength, and I very much wish you the very best for the next year as I try and do my job in Leicester. That's all I really wanted to say in terms of my report. I'm happy to take any comments or questions before we move on. Okay, I can't see any hands up, so thank you for that. Going to hand over now to Paul, who's doing the Chief Exec's report. Thank you.
Thanks, John. Morning, everyone. Just kick off by thanking you, John, and giving you our congratulations. Now you just left your chair, literally. So thank you, John, for the support you've given to the board and the executive team and the organisation over the last few years, and we look forward to working with Claire in a new role as chair. Just a few things to pick out from the Chief Exec report this month. As John's just mentioned, we're unbelievably pleased and proud to win the Acute Trust of the Year award at the Health Service Journal National Awards. It is the most prestigious award that's awarded, not just on that awards evening, but throughout the year. It's a huge accolade for the whole Sherwood team. That's everyone who works and volunteers over all our sites, and for those who support us across the system. And so thank you for everyone for what they've done to contribute to that and help us achieve this award. And again, as John suggested in his update, more positive news came from the National Staff Survey. Our staff have rated the Trust the third best hospital in the country and the best in the Midlands. Again, that's 3 years running on that, and this despite the most challenging year that everyone in the organisation has just had, and we had a really good response rate, 61%, which was one of the highest compared to the others. And we do understand the importance of these results. We know that how staff feel they are treated significantly influences the care given to patients. So that we understand the importance of these. So we're really, really pleased and proud. Just touch on COVID. As we probably recognise, we're past the January peak, and there's a sustained reduction of COVID positive patients in our hospitals throughout March. There's now under 40 patients that we're caring for who are COVID positive at the moment. And on the 14th of March, we marked the first anniversary, the 1-year anniversary of the first COVID patient that we cared for. And we continue to support the vaccination programme. We continue to care for COVID positive patients, and also addressing the growing numbers of patients needing care for other reasons. I'll just finish off by giving congratulations to Shirley Higginbottom for her appointment substantively as the Joint Director of Corporate Affairs for Sherwood and at Nottinghamshire Healthcare Trust. Really welcome the fact that we can work together with Notts Healthcare and strengthen that partnership, and really pleased that Shirley's been adding value not only here but across the system. So I'll pause there and ask for any questions that anyone might have.
Any comments from people? I can't see any hands, so thank you for that. Okay, shall we move on then to the COVID vaccination update?
Hi, morning everybody. It's Claire Teeny, Director of People. Sorry, John and Paul, if I was confusing you there, because I'm just on Simon's PC because I've got IT problems. So if I came up as Simon, I apologise for confusing you as the chair.
That's all right. Distinct improvement.
I'll take that. Thank you. So the details are in the report in terms of the update on the overall COVID vaccination programme that we've been running since early December. Total number of vaccinations through the hospital hub to date are in about excess of 56,000, which I think is pretty incredible. And the hospital hub is supporting the Nottingham and Nottinghamshire vaccination programme. It's one of 9 sites across the county. There's a breakdown of further detail in this month's report, which shows that we've got a total workforce excluding the bank. We've got in excess of 4,700 colleagues now vaccinated. At the time of the report, that was over 87%. We're now over 88%, and we continue to receive people to vaccinate on a daily basis. And the total including the bank means that we've vaccinated over 80%, and that's in excess of 6,000 people. So overall, that compares really well with our flu vaccination programme. We were in the sort of 88% of people vaccinated for flu, but that was for frontline colleagues only. This is total numbers, so it far exceeds the total number of vaccinations compared to flu. The uptake of BME staff, those shielding and those over 60, has been really good and really positive. And regionally, just in terms of how we benchmark, the data for the hospital hub and in terms of our colleagues at Sherwood shows that we are somewhere in excess of 10% comparatively speaking. So I think all of that works really well. The Sherwood Forest Bank has continued to recruit and onboard colleagues to support the whole vaccination programme. We have got over 3,000 people who are now shift ready and are actively working on the programme across the county. And in terms of roster fill rates, they are consistently in excess of 90% in terms of being able to support the vaccination programme, which is all good and positive. People will have picked up that this month the supply of vaccine into April is expected to reduce, and therefore through the hospital and across the county we will be focusing on first doses for those that have not received it and are eligible in cohorts 1 to 9. That's everybody over 50 and health and care staff and those that are clinically extremely vulnerable, and we will also be prioritising those citizens and colleagues that are eligible for a second dose, and that's how the programme will continue to run over the next few weeks. I'll pause there in case there are any questions.
Any comments from anyone? I've got 3 in, so I'll go through that order if that's all right. Manjeet, Graham, then Neil. So Manjeet first. Manjit, are you on mute?
That's it. Sorry. Thank you, Claire. Claire, my question really was about vaccine hesitancy, and I know at People Committee you covered this, but it would be useful to understand what we've done, but particularly what we've learnt with regard to vaccine hesitancy, both for COVID and other vaccinations, and also if you could cover a little bit about the BME as well within that.
Sure. So we've done quite a lot of work both within the hospital and also across the county to support people who've got concerns or queries about receiving the vaccine. They are multiple and variable depending upon people's circumstances. If I speak specifically about activity within Sherwood, and that is a bit representative as well, county-wide, we've spent quite a lot of time engaging directly with specific groups of colleagues to work through any questions. We did a particular series of events with BME colleagues, did some myth busting, answered people's questions, and then on a one-to-one basis as well, people have been able to phone up directly to answer any personal concerns that they may have. County-wide, particularly from a BME perspective as well, we've done a piece of work around that, and we've also enabled accessibility. So into the county, they've been doing some localised vaccinations through community centres, have engaged faith leaders to support the programme, and have undertaken a bit of a roving service around localised community centres and also into the mosques. So there's a series of events and activities that have taken place to enable people to get their concerns answered, and it has actually resulted in a positive response. Just by way of qualifying some of the information, when we talk about BME colleagues and citizens, that of course ranges across a whole group of ethnicities, different religious and faith beliefs. The uptake amongst the Asian community is higher than that of the Black community, and that's where some of the focused effort is now taking place across Nottinghamshire.
Thank you.
Graham, do you want to carry on? Sorry.
That's all right. Thanks, John. Yeah, Manjit's picked up quite a bit of it, and it's really encouraging to see the breakdown that you've got and the work we're doing. But one other category kind of stands out a little bit, which is around the pool staff, which seems to be quite significant as a percentage of our Royal Bank staff that haven't been vaccinated, and how we can sort of, what are we doing to actually do something with that particular group?
So, sorry, Graham, could you just repeat that in terms of the bank staff? What was the specific question? Sorry.
When I look at the numbers on the pool staff, there are 496 that haven't had the vaccine, as against 863 that have. So roughly a third have still not been vaccinated. And that seems to be the most prominent number throughout, and what we're doing about that particular area, because it's, again, they're a key part of our staff engagement.
Yeah, thanks for that. Sorry, I didn't just quite catch the question, so thanks for repeating that. Yeah, so we've done some targeted work with our bank workforce, and our, so the people that work regularly for us are the ones that we've found uptaking the vaccine, and it's the people that are registered with us that probably don't work as frequently that haven't. So we have directly engaged with people. We have noticed that amongst some of the locum workforce that's been a bit more sporadic. We're not sure, however. We're just doing some follow-up work because we think that people may have accessed the vaccine elsewhere, given that they work across a number of sites. So we're doing some data validation just to run through that and qualify that. And we've got that workforce does tend to navigate around a bit. So we are in the process now of contacting everybody directly to understand that. And we're doing some further focus work with our agencies that also supply some of our workforce to ensure that everybody has access to the vaccine. The general feeling is that we think that people probably have, and we just haven't validated and cross-referenced the records. However, just to be sure, it is being followed up.
Thanks very much.
Thanks. Neil and then Claire.
Yeah, thanks, John. Just wanted to ask about the vaccine supplies, Claire. We hear on the national news that we're going to be dropping from around 300,000 people a day, goes up and down a bit, down to a few hundred. I just wondered if we have any idea how that's going to impact on our programme and whether we are going to be in a position to complete the groups 1 to 9 by the middle of April, as the government has promised.
So in terms of vaccine supply, it is still something that we wrestle with. So we are able to order, but you're only able to order quite up late to a deadline. So you tend to order and it comes in the next day. So forward planning is difficult and has been challenging right the way through. Although what I would say is that the vaccine has arrived. So there's a bit of anxiety in terms of those timescales, but it does get delivered. In terms of April, yes, whilst there's a reduction in the overall supply, in terms of cohorts 1 to 9, there is supply to be able to vaccinate colleagues and citizens that fall within those cohorts. The impact is about not being able to open up fully into cohort 10, which is the over 40s. So that's where the restriction lies. But there is vaccine available for 1s to 9 and second doses. And we are really proactively encouraging people that do fall within the eligible categories to book on and have a vaccine, and also to continue coming for second doses. That's really, really important.
Thank you. Claire and then Barbara.
Thanks very much, Claire. Very comprehensive report. I just wanted to pick up on a couple of issues around the DNAs that did not attend, and also the issue of wastage. So first of all, around the did not attend, have we got any sense of the themes that might be behind that? Are there issues around communication of the times for the vaccines or their appointments or some other reason? And do we follow those up? And secondly, the issue around wastage. Again, you know, I think that looks quite a low level of wastage, but I'd be interested to know what that is compared perhaps to the national or to other parts. And what have we learnt around the wastage to ensure that there are lessons we can put in place to try and minimise that? Thanks.
Thanks. Thanks, Claire. So I'll take the first question around the DNAs. The biggest proportion of DNAs for us at the hospital was around people going for their second vaccine elsewhere. And the reason for that was about the focus on care home staff in the first instance. So within the first week, there was a real push to support the vaccination of those working in care homes. As the roving programme set up and other vaccination centres set up, we had people booked on that were then able to receive their first vaccine elsewhere and through other routes. So that was significant in the DNAs. Equally, in terms of second dose, people have received the second dose of the same vaccine, but in their work setting, so in their care home, because it's been picked up by other means. So it's showing as a DNA against our booking system, but it's where people generally have been picked up through another route as the program's evolved. So that's generally the reason why. All DNAs though are followed up. So if there are odd occasions where people are unwell, or they've missed an appointment, or they've got confused because we did need to reschedule some appointments, so they are all followed up so that we ensure that people do access the vaccine. In terms of wastage, so wastage has overall been really low, and I think that the absolute red line is about zero avoidable waste. So in terms of where we've had vaccine supply, and I would say it depends on the nature of the vaccine as well. So with AstraZeneca, it's less of an issue because of its portability, stability, and how it can be stored and for how long. The more challenging vaccine around this has been with Pfizer. and the need to store it at -70, and then once it's thawed to be able to use it within 5 days. What we have learned, and we have a system set up for now, is to be able to communicate across the vaccination centres locally to ensure that we do use it. An example of that, we were going to run on lesser hours today and tomorrow at the hospital hub, because actually we'd got, in terms of the supply that we were fully booked. We've had some last minute supply in to avoid waste at another local vaccination centre, so we've extended the opening hours and we've brought forward some appointments and booked on some new first doses of those that are eligible. So it's a really flexible programme, and the communication across the system is really good. There's a daily check-in to navigate all of this, and I think that's been significant in avoiding waste nationally. And what I pick up off the regional calls is that the same thing has applied. So rather than waste vaccine, the message has been give vaccine, even if you need to be a bit creative in your thinking, and that's what people have done.
Okay, thank you. Barbara.
Morning, Claire. Thanks very much. Really comprehensive report. I'm interested in the relationship between the staff who have yet to take up or didn't take up the flu vaccination and the cohort here who have yet to be vaccinated for COVID. I'm wondering what the overlap is between the two.
So I think some of the reasons are some of the same, in that where we've got a flexible people within our workforce, we don't always know, and that's not something we've been great at tracking either, Barbara, around flu. So we've tended to focus mainly on our substantive workforce and frontline workers. In terms of the other correlations, I think they are generally down to some of the things that we've discussed. There's some hesitancy based on some say cultural differences and some myths around vaccines overall, that we've worked really hard to try and dispel, particularly this time around. The other thing that I am picking up, where I do think there is an overlap, is around people's circumstances. So if they are ill for other reasons, and for those colleagues that may be in their latter stages of pregnancy that are not saying no, they're just saying not now, and they're away from the workforce, they're away from the workplace. And I think that some of that overlaps as well. There's some of the themes, but I think that there is more detailed work to do. And I know that at a higher kind of population level, through the health and equalities work that's being done, they are looking at all of these correlations around population, flu vaccination, uptake and acceptance, and what, if anything, has happened with COVID. So in terms of the absolutes, I don't think we've got all of the answers on that data yet.
Thanks very much indeed.
Okay, thanks. And Dave, I think you wanted to make a comment on the wastage.
Thanks, Chair. I was just going to support Claire in the very low level of what I would call avoidable wastage. We did have one incident really relatively early on where in our freezers one of the shelves collapsed and the tray of vaccines fell to the ground in the freezer. And we discovered that. Now we talked to the company about that, and they had no data on the stability of the drug. You'll be aware that Pfizer is very unstable. They had no data on the stability of the drug falling from a height, and so we're advised to waste quite a significant quantity there. So that does account for quite a lot of that. Have I got that right, Claire?
Yeah, that's correct, Dave. We did have that accident quite early on, and that's a level we've counted that in the wastage, even though it was an accident. So that further reduces actually the total figure of what we would call avoidable waste.
Okay, thank you. Well, thanks for that, Claire. Thank you very much. Shall we move on then to the maternity update? Julie.
Thank you. So 4 things to highlight for you today. So postpartum hemorrhage of greater than 1500 mils is flagging again this month, but we've validated the number, and actually when it's been validated on the DATEX system, it's reduced the number from 9 down to 5. So actually that is not actually a red flag as it appears on here. There are no lapses in care in any of those cases. They've all been reviewed through our triggers meeting. There were 2 stillbirths sadly in month, both where the baby had passed away on arrival to the unit. Both of those cases have been reviewed, and again, no identified lapses in care. From an FFT perspective, you'll recall I reported last month that we'd done a deep dive into this, and there were 19 responses received, which is extremely low. We looked at the timing of text messages, and we've changed the timing of text messages, and we've reintroduced paper surveys. So the response rate has increased up to 55 this month, and we know in March it's gone up to 105 so far. So we're seeing an improving picture there. There were 63 incidents in February. One of them is on the scorecard as moderate harm, and that was a staff fall outside in one of our car parks. And on review, that's actually a low harm incident. So all of the incidents were of low or no harm. Happy to take any questions that people might have on that update.
Manjeet, I think you had a question.
Yeah, thank you. Thank you, Julie. My question was, you know, on the stillbirth data, it gives an average, and I wanted to understand it more in terms of meaningfulness and in terms of understanding, you know, as a trust, how do we compare in terms of number of deaths with the worst trusts and with the best trusts? Because it's a low number, isn't it? And I just wanted to understand the meaningfulness of this statistic, really.
So actually we perform very well. There is a report coming to private board that shows some national data that's come out, and Sherwood, Nottingham as a county performs well, but much of that is driven by Sherwood. So actually we do perform very well. I can it's in the next report, but it is a very good picture, but obviously we have had 2 in February that has just increased that rolling average for this year.
That's it. Thank you.
Okay, thank you. I haven't been notified of any other questions. So, Julie, anything else from you?
No, nothing from me. Thank you.
Okay. Well, thank you very much for that, Julie. Thanks. So, Claire, do you want to add anything, given your role as the NED lead on this?
So, John, just to say that we are continuing our visits around maternity and neonatal. Indeed, it was a very nice visit last week before, an opportunity to see triplets on the neonatal unit, which is an unusual experience, I think, for this trust. We don't see many of those, so some fantastic care going on, and really good opportunity to talk to staff as well. So the visits are going well, and our regular monthly visits, along with the monthly maternity safety check meetings.
Thanks, Claire. Okay, well, thank you, Julie. Thank you for that. Is Alison here yet? Because we're a little bit early, aren't we?
I am here, John.
Oh, great, lovely. Welcome, Alison. So
Thank you.
I hand over to you for this report?
Yeah, thank you very much. Yeah, so I just want to give a quick overview of the last year in R&I and what's been happening. Obviously, like anywhere else, it's been quite a different year. So in terms of performance, most of our activity this year has been in urgent public health studies that we've delivered, obviously, to try and combat the pandemic. So just looking at some of the figures, just wanted to highlight the recruitment for this year. So that's running at 3,039 recruits into studies against a target of 2,500. So it's a little bit less. So I'm sorry, just on the graph, it does say 3,003, but we've just done a final data cut-off last night. So there's a few more recruits on there. It's obviously a little bit less than last year because it's kind of been a different programme of work, really. And then just to split that up into non-commercial and commercial activity, and that's the graph underneath. So you can see that commercial activity has dropped quite significantly compared to last year. And then there's just a small drop in the non-commercial activity. When we look at recruitment by speciality, normally we have quite a nice range across all the specialities. And you can see activity is centred around a lot of specific specialities, obviously particularly respiratory, because a lot of the UPH studies would have been in that speciality. We've got significant recruitment in gastro and ED, and some in critical care and in obs and gynae, and that reflects again some of the UPH studies that have been happening in those areas. We also just wanted to give you a brief overview of our 5-year performance, and we submitted this towards the HSJ presentation. So you can see a nice increase in recruitment at Sherwood Forest over the last 5 years. And then obviously we've got a little bit of a dip this year because of COVID studies. We do like to benchmark against other trusts in the region and other trusts of a similar size across the UK. So at the moment across the region we're 6th. We have dropped a little bit from 4th from last year, and I think this is just because of the nature of the studies. Obviously acute trusts have been doing a lot more urgent public health activity and have been able to recruit lots more participants to these studies. Looking at trusts of a similar size, we're 4th, and we're going to do some work this year to have a look, actually, interestingly, to see what Liverpool are doing, because they've got absolutely outstanding rates of recruitment there for a trust of that size. So we're going to do a little bit of benchmarking and see if we can learn some lessons from those trusts this year. And then we go on with the next slide, please. So we just go on to look at finance. So looking at finance for the year coming, the networks have done a rollover budget this year, so we receive exactly the same amount of income that we received last year, and that's positive because normally there is a slight reduction in income. Commercial income that we have created this year is around about £86,000. It is quite a lot less than previous years, and that's because most of the commercial activity has had to stop, and we haven't had income coming in. This figure on screen, this is the total income that's come into the Trust for Research, and some of that income will have been diverted to the divisions for the activity that they've done. We do get every year £20,000 from Department of Health, and that's to maintain capability and capacity, and we're looking at how we use that year on year. With the next slide, please. We have continued to do the patient experience survey, although this year, this is the NIHR national survey. However, this year it has been focused around participants in the Siren study, which is the NHS staff study. And we've had some really good responses to that. So this was sent out to everybody who participated. So 98% of participants who completed the survey agreed or strongly agreed they were treated with courtesy and respect. And 96% of participants who completed it said that they would consider taking part in research again. There's some of the comments there, and we have been looking to work on any negative comments and how we can improve. Some of that has been around people wanting to know their antibody result, which unfortunately we don't have at the Trust. The antibody test we do here is different. It's only Public Health England where these samples get sent off that actually can report back whether people's got antibodies as part of having the vaccines. So next slide, please. And then also we're now coming to a point where the cases are starting to stabilise, and we need to look at how we actually restart our research activity. So we did suspend, you know, significant amount of studies, and this happened within a sort of 2-week period. It was a really rapid response to change in our research profile across the trust. So before COVID, we had around 74 studies open. We had to suspend 58 of those and kept 16 open. Those studies were around some of the cancer studies and some of the studies that we're using investigational medicinal products, that if we'd have stopped them, that would have created some kind of safety risk for those patients taking part in those studies. During the first and second wave, we did restart some studies, so we've been working in the lines of the NIHR framework for restart, and we managed to open 23 studies. Unfortunately, with the second wave, we weren't able to progress that any further, and some of the activity on those studies that we did reopen had to slow back down. So if we look at the studies that we will have once we open the rest of our portfolio again, we'll have around 60 studies active. Obviously, that's, you know, a decrease in from where we were before, but we're really happy to say we've already got 22 studies in setup ready to open. So despite doing the UPH activity, underneath we've always been starting to look at what new studies can we get in, what commercial studies can we get in, so that we don't have a, you know, significantly depleted portfolio as we start to come out of COVID. I just want to reassure you around how we restart studies, so we're not just going to suddenly blanket open the whole portfolio. We do have an R&I assessment and prioritisation group. That group meets weekly, and we reassess quite closely that all the conditions have been met to open a study safely, and that it's not impacting on the particular service that study is related to. We do provide a matrix each week of studies we'd like to open, and we've that was originally sent to the deputy Q, but now that's going to be sent to Tabitha Darman, so that we do have some agreement from the trust that they're happy for us to open that portfolio. Also, I'm not sure if you know, but there was a national policy came out in January from the Department of Health. That's called UK Clinical Research Recovery, Resilience and Growth. And that's basically a paper talking about supporting restart of research, but also actually looking at how we can build onto this and actually grow research even better across the UK. In my lifetime in research, this is probably the most significant spotlight on research I think we've ever had, and it provides us with a fantastic platform to understand, you know, the importance and the impact it really can have on healthcare. So we're hoping to maximise on that at Sherwood Forest, and we continue to progress our work with trying to embed elements of research within divisions, and continue to progress trying to find that research space that we were successful just before COVID, but sadly obviously that's changed matters, so we will progress that, because that's going to be still a key factor in increasing commercial research activity. Okay, I think that's the final slide, isn't it? If anybody's got any questions.
Thank you very much, Alison. Yeah, that was really good and really, really impressive. I think what you've done, and given all the uncertainties and everything else, I think it's really impressive. And actually yesterday in my inbox arrived a summary of that clinical strategy you referred to. NHS providers do them, they're quite good, so I'll make sure that's circulated to our two members of the board as well, so they are aware of that national strategy, because it seemed to me that there was some opportunities coming out of that.
Yeah, definitely. And one of the things around that is, so the NIHR has been given an extra £30 million to put into research infrastructure across the country. That's been shared with the clinical research networks, of which our networks got around about £3 million. So we are going to get some extra income this year. Our percentage will be around quite small, around £20,000, but there are also a couple of priority funds that we can bid for extra income, and we're already working with the CRN speciality lead in oncology, and we've got a meeting with Penny and Steve later in the month to look at how can we increase our oncology research. So we're hoping to place a bid that as well. We've also been supported to employ a couple of new staff from the network. So that's fantastic. That's not sort of resources that we would normally get. And also I just wanted to say a massive thank you to all the staff at the Trust, for taking part in Siren. We couldn't have done that without people being willing to participate and get jabbed every couple of weeks. And also to all the staff on the clinical areas, because these studies would not have been able to happen without collaboration with those team members, and our team were welcomed onto the wards and supported really well, and that's been fantastic. So we're so grateful for that.
Lovely, thank you. I've got three people so far. Julie, then Simon, then Dave. So Julie.
My point related to the last paper, John, it was just to note Manjeet's question around stillbirth, which at Sherwood is 2.92 per thousand compared to 3.51 per thousand, so benchmarks well. Okay,
thank you. Thanks. That's just on the previous item, Alison, but thanks.
That's okay.
Simon.
Hi, Alison. Thanks.
Hi.
Thanks so much for that. I think you're probably on Liverpool. You're probably not comparing like with like, because all the trusts have merged in that city now, so that's an enormous trust. So probably take them out of the benchmark. Okay. My question was more related to the sort of time it takes from research to reality, if you know what I mean. So things getting sort of patients feeling the benefit of research. And my hunch is that during COVID, particularly with regard to COVID, that time has really shortened in similar way to the time to vaccine has shortened. Do you think that this will change how long it takes from sort of approved research to actually patients feeling the benefit in other areas? Do you think there'll be something that will change around that?
That's an interesting question, Simon, and I can't say definitively, but I'd like to think that the sponsors of research, have sort of learned lessons from this, and as part of that policy, that will be one of the things that does come out of it. One of the priorities around communication between research groups. So I hope that will be the case. I mean, it's been incredible, particularly for the recovery trial, that we've seen within months of a trial opening an impact where a treatment has now become standard of care. And I've never seen that in my lifetime. In terms of drug studies, we're normally waiting 10, 15 years before a study comes to market. But I guess it all depends on the regulatory authorities as well, for things like IMPs. But for things that aren't regulated by those agencies, it would be nice for sponsors to have picked up, actually, we can do this. For example, it used to take around sort of 3 to 6 months to set up a complex study. Some of these studies we set up within 5 days. So we've shown that we can do it. And I think a lot of it has been around flexible working, and a lot of it is about being sensible around risk. I think sometimes in research and research governance, there's always been, a really heavy focus on risk. And actually, it's not always necessarily being sensible. So I think we will learn and definitely grow from that.
That's really helpful. Thanks, Alison.
That's good point, Simon. Dave.
Thank you. I might just pick up on Simon's last point. A really interesting point, Simon, actually. So I would support Alison's. There's definitely been an improvement in the collaboration and streamlining the process, be that the ethics approval or be that how we get these studies funded and up and running. I think I would just be mindful, or ask board to be mindful, that all of these studies that have come on as a result of COVID, the treatments are all off license, and what that means is that we really don't know the full efficacy and the risks of this, and that will take some time, and so there is a risk to pushing all of that forward. But that will come out of it, and obviously we've had discussions before about risk appetite within COVID. The comment I was going to make to just support Alison, this has been an incredible year, I think, for the research department. I think there are real huge opportunities going forward, as you highlighted, John. The powers that be have noticed that genomics and some of our ways of doing studies in this country prevent us real opportunities to be world leaders, and there's been some funding released to support that, and I would hope that we take that opportunity. In terms of building on that report, what I'd just say for boards information is the first two studies, or first 2 or 3 studies that in Alison's report, the recovery study and the REMCAP study, those are the 2 studies that have primarily delivered the current treatments that we have in COVID, so the dexamethasone and the tocilizumab treatments, and particularly in the recovery study, we've been an extremely successful recruiter in that, and we've had I think a significant degree of praise about our ability to recruit into that study, and these are very different studies to the studies we've done before. It picks up a bit on what Simon was saying. These are what's called platform studies, and it's where you add on a treatment as to an arm, and then you run it for a period of time and you stop it. It's really very different to how we've done studies before, but I'll stop there because I'm straying into Alison's territory.
Thanks, Dave.
I mean, I think your comment on risk appetite is quite interesting, and something maybe the wider part of the wider discussions you were referring to, Alison. I mean, if we just look at the risk appetite that different governments have around, say, the AstraZeneca vaccine, it's clear that some have in terms of, risk on taking that in terms of effects, they've got almost a zero, but they're quite happy to take a huge risk appetite and on the sort of likelihood of people getting COVID. So it does seem to me that we're seeing very different aspects to this, how you balance these different risks. And I think Dave's point is important, but it does seem to me that aspect is going to be one part of the discussion with the regulators in terms of how they balance that and against speed. But thank you. Paul, you had a comment, I think.
Yeah, thank you, John. Just wanted to thank Alison for the presentation and just reflect that each time Alison reports to board, we see the developing improvements that her and the team are bringing to the research capacity and capability at Sherwood, and just huge thanks to Alison and the team for that. It's hugely beneficial to the trust in terms of reputation, but that's not significant when we look at the improvements and benefits that it brings to research and patient care for the future. So thank you, Alison.
Thanks, Paul.
Yeah, no, I thought it was really impressive. And can you take the board's thanks to your team?
Absolutely will. Thank you.
What they've done during a very, very challenging year. So thank you very much for that, Alison.
Thank you.
Okay, good. Shall we move on to MSK? So Jane and Tilan, are you both here?
Hi, I'm here.
Great, thank you.
I think Tilan was struggling to log in as a presenter and might be in as a public observer. I've just resent him the link.
So. Well, that gives you huge scope then, doesn't it, Jane? So
well, that's fine. I can do the whole thing. No worries.
So shall we kick off in terms of that, and then Tilan, if he can join in, can join us as well and follow that up. Okay, thank you.
Yeah. So I'm just going to share my screen if that's okay.
Yep.
Jane, if you're struggling, I can share your presentation for you.
Can you do it? I haven't done it on one of these formats before. That would be great. Thanks, Robin. Tilan's just joined.
Oh, good.
Just in time.
Hi, Tilan. You all right? Okay, Jane, do you want to kick off? And hopefully
so, hi, thanks for having me and Tilan when he arrives to your board meeting. It's great to meet you all. My name's Jane Ferreira. I'm head of MSK Together, so that's the integrated MSK service that is running in Mid Nottinghamshire. And Tilan is Dr. Tilan Bartholomew, who is the clinical lead for Mid Not's ICP. So we can just move on to the next slide. Thanks. So we know times are changing. It's all, it's all we're talking about at the moment. We've got the end of the quasi market and we're moving to more collective accountability. So we're starting to move away from that kind of purchase provider split. We've got lots of changes in the system, ICSs, ICPs all evolving, and we're starting to focus less so on the kind of institutions that we work in and more looking at the population that we're serving. So specifically in MSK, we're looking at the population of people who have musculoskeletal conditions, and certainly on a background of COVID-19 we've kind of been exposed that potentially we've got some equity issues within our system and what the importance of that is and how we can start to address that very quickly, but also the need to use our finite resources as wisely as possible. So we know the financial situation is not looking great, and we need to make sure that when we are spending money to make our patients' lives better, that we're spending it on the best things that we can, best value for money, using evidence-based interventions, and also trying to deliver on what patients actually want to achieve in their lives. So if you just flick the next one through, please. So now we know that the new government white paper has shown us that in legislation we're now going to be held accountable for a triple aim. So this triple aim focuses on improving the population's health, so looking at the wider health of the population, improving specific patient outcomes, so that's on an individual basis, and also providing the money for value for money for the taxpayer. So that is going to be something that we will be having up front and centre when we're trying to make sure that we can deliver our services. Next one, please. So when we've linked that back to looking at the Ics-Wide system outcomes framework, and we know that healthy life expectancy is up front and centre, improving healthy life expectancy and reducing the gap in healthy life expectancy. So that would link in with our first, improving population health. Then we're looking at individual patient outcomes, and I'll go on to that shortly. And then also we've got to really focus on the resources that we're using to achieve both these population and personal outcomes and be able to link them all together in a kind of systematic way. Next one, please. So MSK Together has been on a bit of a journey. It started back in kind of 2017, it went live, but this project has been supported by the Oxford Centre for Triple Value Healthcare, which is known as 3V for short. And essentially, as an ICS, ICP and CCGs, we all agreed that we wanted to try and set up an exemplar project to try and see how we can work in this new way to deliver on that triple aim. Next one, please. So we've been building on the work done in Mid-Knots. So we know that in Mid-Knots we've got a strong integrated MSK service already. We've got partnership working. We had some issues with the kind of bilateral contracting, but generally, the frontline clinicians want to do the best they can for their patients, and they're happy to work together outside the boundaries of their institution. So we had a really good kind of starting point for this kind of project. So the next thing we did was we engaged in our population. So we asked our patients, we used patients who were on orthopaedic caseloads, rheumatology in the MSK service. We sent out loads of questionnaires and we said, what matters to you? What's important in your life? What outcomes do you want to get when you are receiving musculoskeletal care? And what things do you think we don't do enough of or too much of? And then we followed that up with some semi-structured interviews, and we got some really rich data and feedback from the patients to be able to form a list of our personal outcomes, so we know what outcomes matter to the people in Mid-Knots, and we can start to deliver our services to try and achieve those. Next, please. So then we got together as MSK Together, and this is orthopaedic consultants, rheumatologists, physios, clinicians, managers, a whole mix of people, active knots, some people from reverse arthritis, and critically we've got 2 patients in our group as well, and we came up with an agreed aim and principles of how we're going to work together. Our aim is to deliver best outcomes and best value for money, and we had a set of principles on how we're going to do that and how we're going to work together, and essentially that's how we're going to be judged as a service moving forwards. Next one. We then brought together a comprehensive analysis. So we looked at what the picture is at the moment. We got the evidence from activity going on in hospitals, what outcomes are we getting, what money are we spending, what does it all look like right now. And although that document is really interesting and informing, actually the biggest thing it did was start to stimulate conversation between this group of clinicians and this team to say how we're going to start to do things differently and how we're going to make things better, regardless of where our organisations lie. Next one. So then we started to generate these value improvement ideas that we want to test. So we've got ideas. We want to look at hips, knees and backs. We want to look at fibromyalgia. We can see different parts, looking at the data where we've got some good opportunity to really make this much better to be able to optimise the outcomes for patients. Next. So fundamentally, we are a group now. We are a collaborative group from different organisations. We've got Notts Healthcare, Sherwood Forest, PCNs, PICS, Active Notts versus Arthritis, a whole team of people, CCG, all looking at trying to deliver on this aim and principles to get these best outcomes for the population that we serve. Next one. So what we want to be doing essentially is to be given greater authority and responsibility to be able to use these resources that we have to benefit people in Mid Nottinghamshire, and that's really to be held accountable for the triple aim. So we want to be held accountable for making sure that we in MSK are improving the healthy life expectancy of people with MSK conditions, we're improving patient outcomes of people with MSK conditions, and we're using the kind of financial envelope that we have allocated for us to make sure that we can use that money wisely. Next one. So our next steps really is just agreeing, with all of our partners, and we've had discussions through the ICS at Sherwood Forest Execs, this board now as well, and we're just trying to make sure that everyone's kind of on board with what we're trying to achieve and understands what we're trying to achieve. We want everyone to say, is this what we want to do? And if not, then what's the other options? So we're kind of part of leading a change, but then there'll be some kind of technical bits that we need to move forward with. So how do we start to move the finances around? How do we make our contracts so that it supports the ways of working to optimise the patient's outcomes? We need to start looking at dashboards that have got less of a focus on activity, although we need to obviously understand activity and volume of stuff. We need to also be measuring the outcome and looking at the spend and trying to triangulate and make sure that we're going in the right direction with the different changes that we make to the service. We need to just make sure our governance approach is suitable in the new system, and how that all fits together is kind of a bit of an emerging field. And then effectively we want the agreement from the system that this value framework is how we're going to move forward and look at that kind of more strategic commissioning and looking at a needs-based allocation of resources. Next one. So our next steps are developing the dashboard, which is something that we're doing at the moment. We're going to look at some different technical resource processes to try and check through our 3 conditions that we're making sure that we're allocating resources in the most cost-effective way. Next steps, and ultimately what we're ready for is to move forward with the project, and we're just working within the system now to make sure we get all those difficult things that are probably quite new and different for ways of working with the finance, the contracts, the governance, and take that next step to make it actually happen. The rest of the appendices are for people to read at their leisure, because they're just to inform the presentation really.
Thanks, Jane. That was sorry, I've got some strange feedback. Okay, no, that was really good. Thank you very much for that. It's really good to see something sort of being rolled out actually right the way across Nottinghamshire, developed in one area, and I hope we'll see more and more of this where stuff's developed in one area and then rolled out in the way you said. So I think that's really, really excellent. And Neil, I think Neil, you had a question?
Yeah, thanks, John. I just wanted to ask if we know when we'll be able to see a plan of the actual concrete actions being taken, and how we expect to measure the outcomes of those actions. Because if we take, for example, improving population health, what are we actually going to do to achieve that, and how do we measure whether we've been successful or not?
Yeah, it's a really good question. So measuring healthy life expectancy, which is the upfront outcome within the ICS, is actually quite tricky. So it's often related to its EQ-5D, which is a quality of life measure. And we know that, you know, we always think that healthy life expectancy doesn't change very quickly, but because it's so related to somebody's quality of life, if someone reports to have a better quality of life, then their healthy life expectancy is immediately changed. So we're currently designing a dashboard, excuse me, and working with the population health team in the ICS to make that a reality, so we can pull the quality of life data, we can pull pain data, we can pull personal outcomes, and then that gets transferred into a healthy life expectancy years, basically. And we should be able to monitor that kind of real, you know, as real time as like on a monthly basis to see those changes. With regards to the plans for the value improvement project, so we've got some kind of rough plans drawn out with regards to the focus areas, and we'll be focusing on the kind of prevention piece, looking at access into primary care services, what happens in the community, and then the secondary care. So those kind of project plans will evolve as we start to measure our output, but it's one of those things where we need to really have that kind of data, that baseline data, to be able to help us make decisions, because that, although data is only one form of knowledge, it's actually quite an important one. And having a look at all the outcomes that we've pulled from the system from the last couple of years, understanding the impact of our services has actually been quite tricky to pull together.
Can I just follow up on that? Looking at it from the financial side, because one of the sort of things that's coming through increasingly is that actually if we're going to deliver savings or increase efficiency, it's got to be as a result of system-wide things such as, you know, this system-wide initiatives. And but I think the jury is still out to the extent to which that really will release resources, etc. So is that also part of the sort of benefits matrix, if you like, or do you not see that coming through so much?
So when we look at how we're moving into the new world, we're looking at the allocation of resources, and we know that the spend in mid-knots MSK is just under £28 million. So if we're saying that if we're allocated that £28 million for MSK, then there's no more. There may be less, but that's a conversation to have, you know, through the ICS, kind of allocating different pots of money to different population segments, and then we'll need to work within that financial envelope. So what we do differently over here, if that does change the financial model, then the idea is that money is reinvested kind of upfront into the community lines, or wherever we feel would have, you know, using the evidence would have the biggest benefit on the population outcomes.
Okay, thank you. Barbara and then Dave.
Thanks very much, Jane. So I was really interested in on slide 27, where you make the statement that compared to people from the least deprived areas, people from more deprived areas, there's a 20-year earlier gap in terms of access to services. Is that evidence from local experience, from mid-knots, or is that a national stat? That's a local.
That's mid-knots. So when we mapped out the kind of access to hospital services and the age and the deprivation, we called it kind of like a tartan rug, because it was kind of red, green and yellow, and it did show that kind of stark contrast of the access to hospital services that's associated with deprivation.
So that's really interesting. So that's that equity of access to services. Did you look at it as equity of outcome, sort of the impact? Because we have been, as a system, using some outcome measures, particularly for knees and hips, for a little while, as far as I know. Was there a similar pattern for outcome?
So when we looked at the outcomes, which is collected on the National Joint Registry, so you've got your EQ-5D, your pain, Oxford hip and knees, there was no real change. So with the introduction of the hub, so the MSK hub, which was kind of put in place to help with equity and reduce unwarranted variation, what we found was that the volume of activity going into secondary care overall reduced, but the outcomes haven't necessarily improved. So you'd want to see that, you know, if we're getting the right patients into the surgery, the outcomes should all be really good, but there was still a proportion of people who didn't do so well. What we also know about the hub's capacity is that it doesn't have the capacity to see everybody. So some people do go directly into secondary care still, and some GP practices do continue to bypass the hub, although that didn't actually also have an effect on the unwarranted variation. So the big key part of the hub is the shared decision making process. So patients who come through the hub, they have a shared decision making conversation, they understand all the impacts, and we try and talk about, you know, what outcomes, what do you think you would get from a knee replacement, what do you want to have, you know, we have those kind of difficult conversations or in-depth conversations to try and optimize it. So you could argue that if people have had an unwarranted a shared decision-making conversation, then that would reduce unwarranted variation as well. But there's definite work to be done to really try and hone in on those outcomes and monitor them and make them, you know, go in the right direction, so that we are truly getting the right people in front of, you know, having the surgery and optimizing that surgical procedure.
Great. It's really good to see looking at equity of access and outcome, because sometimes we look at one and not the other.
Well, exactly. And the idea with our dashboard would be to triangulate it all. So we'd be looking at, you know, we'd be able to cut it by PCN. So we'd be able to target, you know, focus our attention on certain populations. We'd be able to then triangulate it with the spend. So getting this dashboard in place is really quite a critical part of moving forward with the project.
Thank you.
That's excellent. Thank you. I've got a couple more, Dave, and then Simon.
So I think I'm just building on that last point. So Jane, thank you as always. So this clearly feeds into our perioperative care work, and it's a core component of that. And Jane is aware of how important shared decision making is with that. But of course, with that perioperative care program, the end result is not always surgery, and we have to be mindful that there are other treatments or pathways that we need to stream our patients into, and that those come with different outcomes. The other thing I would say, you were talking, Chair, about some of the financial aspects. This particular pathway, and certainly MSK, it's a real there's a lot of interest in, for example, opioid usage in these patients. So MSK patients, there's a very high incidence of them being on strong opioids before they come to their definitive treatment, and then there's a high incidence of addiction with all of that, and there's some real financial opportunities as well as population health opportunities of changing that and altering that and reducing that enormous tsunami of opioid usage that we've seen in some other countries, and we want to try and avoid here. So I was just fleshing that out. And I can see Jane's nodding.
Yeah, and we do. I didn't mention them, or they'll kill me. But I did. We have got PICs in the room as well. You know, we work really closely with PICs, and they're an absolute key part of designing how we optimise the services and what they can deliver, what we've got to deliver, and where we want to focus our attention for managing some of these patients. You know, MSK isn't just a twisted ankle. They're long term. It's like managing a long term condition for a large proportion of people, and it really does impact negatively on people's quality of life and hence healthy life expectancy. And there's probably a lot more that we could be doing, you know, to redirect and channel. Like Dave said, you know, surgery is not, it's a great answer for a lot of people, but it's not the best answer also for a lot of people. So we just really need to work that out.
Lovely, thank you. And Simon?
Hi Jane, thanks for the presentation. Just in terms of sort of going from where you are now to where you want the service to be, what are you looking for from Sherwood Forest Board to sort of help you with that?
So I think, you know, I think we are doing slightly different and new things. I know we had the attempt of kind of a capitated budget with MSK previously, and that kind of didn't happen for whatever reasons. We've got a similar programme with end of life, but really it's coming into the conversations, understanding the different ways of working, agreeing to trial these new financial models and you know and kind of get involved and from the I guess from that leadership is to show that this is the way we're doing it, this is what we want to do, and supporting it from, you know, be visibly supporting it from the top as well. So to, you know, potentially any unblocking, I hate that word, but you know, it makes us sound like we're all a load of bricks working together, but you know, it's trying to smooth the way as much as anything as well.
Okay, thank you. That was really good. Thank you very much, Jane. And can you thank Tillan? I know technology got in the way, but I know he's provided an important role in all this as well.
I know he has. He's texted me, said he's still stuck in the public domain. So sorry, Tillan.
Well, thank you, Tillan. Luckily, I think quite a lot of the board have met him at various times, so that's yeah. But can you pass our thanks on to him and indeed the rest of your team? That's absolutely brilliant. Lovely. Yeah. Thank you very much.
Great. Thanks for having me. Thank you. Bye bye.
Okay, so if we now come to the patient story, I know Francesca's joined us. Deborah, are you here as well?
Yes, morning.
Lovely. Hi, how are you? All right.
I'm good, thank you.
So welcome, Deborah and Francesca. So can I hand over to you, or Julie, do you want to say any introductory things or not?
No, I don't think this one needs an introduction. It's a great story. Thank you.
Lovely. Thanks a lot. Okay, well, I'll hand over to Deborah and Francesca. Thank you.
Thank you. Good morning, everyone. I'm Deb Elliston, lead nurse for End of Life Care, and I'm joined to present this story today with Frankie Jones, who is the ward leader on Ward 21. We wanted to share this lovely story with you today as an example of true patient-centred care that demonstrates how collaborative working led to a married couple being able to spend their last few hours of life together on Ward 21. As often happens, we only see a small snapshot of someone's life when they are admitted to hospital and into our care, but this story will show how many of us were privileged to share more of an insight into the life of two people who were clearly devoted to each other for nearly 70 years. Much of the personal information we have is through the eyes of their niece, Sheila, and Frankie will explain more shortly. During the story, we're going to look at some of the challenges that were encountered in order to make this happen, including some of the difficult decisions that could have influenced a very different outcome. So I will hand over to Frankie now to set the scene. Next slide, please.
So this is the lovely Mr. and Mrs. Bacon. They were both born locally in Sutton in Ashfield and worked local for their whole lives. They met each other and were married in 1956.
Next slide, please.
So Derek was an inpatient on Ward 21 from December 2020, and every day he would wander up and down the ward and we'd be looking for Marion and shouting out, "Where's Marion?" So Derek had a dementia diagnosis and Marion was his main carer at home. When the ward were made aware that Marion was an inpatient in the trust, Marion was moved to the ward to be with Derek. Each day we would get the couple up and dressed, and Derek would walk the length of the ward to sit by his Marion's bedside. There they could share their day together, and this particularly was calming for Derek to be back with his beloved Marion. Mr. and Mrs. were both discharged to the care home Kingfisher Court, leaving the ward together hand in hand in the same ambulance.
Next slide, please.
Marion came back into the trust on the 23rd of January and was moved to Ward 34, where she was made end of life and received care there. Derek came back into the trust the following day following a fall in the care home whilst he was searching for Marion. He went to Ward 53 and received care there. The family had requested that Derek visited Marion on Ward 34 to say his goodbyes to her, and it was identified at this point that both patients were once again in the trust together. During the winter period, Ward 21 has 6 to 8 dedicated end-of-life beds to help with winter pressures and the COVID pandemic. Marion was identified by the end-of-life clinical nurse specialist to come to 21 for her care. The ward also reserved a bed space for Derek to receive care on the ward, so each day he could spend it by Marion's bedside. Derek quickly deteriorated after he'd visited Marion on Ward 34, and he was also made end of life. As they were now both receiving end of life care, we knew the patients on the ward and had reunited them previously, the ward felt we could do this once again for their final moments.
Next slide, please.
We faced many challenges during that shift, and I'd like to take this opportunity to thank Chief Nurse Julie, the heads of nursing Trevor and Carly, matrons Marie and Jane, all the porters, the MediRest team, and all the staff on wards 34, 53 and ward 21 for their help that day. So the challenges were which room would be suitable to put the couple together in, thinking about the safety, and was it safe to have 2 beds side by side in a small cubicle. One patient was COVID positive and one patient was negative. Was it the right decision to move these patients and put them together and put the other person at risk? So this was discussed with the infection control team, and they gave full support for the nursing decision. We were also aware of breaching the single sex occupancy rule of Sherwood Forest, and all the ward beds were currently occupied at this point. So to accommodate this move, we needed to move several patients around the ward. This took careful consideration into patients' needs and all patients' safety. We also took into consideration the family's wishes, and after a lengthy discussion with Sheila, the family understood the risk, and they expressed that the couple had always said that they wanted to leave this life together.
One of the challenges we faced was making the decision to move Derek, as it was clear that he was rapidly deteriorating when me and my team reviewed him that day. When I saw him, his breathing was laboured with long gaps between breaths. His hands and feet were becoming mottled and felt very cold. I stayed with him for about half an hour, and this pattern didn't really change. At times I could feel myself almost breathing for him, and I really wasn't expecting him to live for very much longer. At this point, there was still no rush to finally decide whether to move him, as the room wasn't quite ready to receive him on ward 21. So we gave him some medication to ease his breathlessness and made him more comfortable, and I explained to the staff nurse on ward 53 that I would come back in about 45 minutes to review him. I can honestly say I really did not know which way this was going to go at that point. I returned as promised, and he didn't seem to have changed that much, so I sat again with him for about another 20 minutes. At that point, my phone buzzed, and it was Frankie. She asked me how he was, and I explained it was still touch and go. She said very calmly the room was now ready and that Marion was on her way. She also explained that she'd spoken with the family and they desperately wanted this to happen. I asked if they knew the risks of us doing this, especially that he may sadly die on the way toward 21. And Frankie had explained all of this to them, so we had this one window of opportunity to make this happen, and we took it. Frankie came up to ward 53, and we both brought him down to the ward 21 together. I can remember that we said our hearts were beating so much as we got him into the lift, and I remember Frankie saying, "Hang in there, Derek, your Marion is waiting for you downstairs." In the 30 or so years that I've been working in palliative and end-of-life care, there have been many examples of people I've nursed who were so near to death, but have hung on for a while longer because they knew their brother was travelling from afar to see them one last time, or knowing they were terminally ill but have managed to attend their daughter's wedding and then peacefully die just a few days later. And I really have no science to explain this at all, but Derek's laboured breathing that I described earlier settled, and he became incredibly peaceful whilst we travelled in the lift, as it appeared he knew his Marion was waiting for him. Next slide, please.
So after we'd moved the patients and reunited them back together on the ward, this truly was the highlight of my career, just to see Marion's face. She was totally aware that she was now back with her husband at her side once again. She looked truly content, and Mr. and Mrs. both visibly settled down. Myself and Deb came out of the bay and we just collapsed at the nurse's station. We were so emotionally exhausted and absolutely elated that we'd managed to make this happen for the couple. We made a phone call and spoke to the niece Sheila, who was crying and so happy that we'd managed to reunite them and that they had made it to the ward safely. We knew that after 65 years of marriage that we could make this happen, and that we were so glad in that moment that we did.
Next slide, please. We would like to conclude by looking at the positives of this story. As you will all know and feel, there have been many things that haven't been possible for us to provide as we usually would throughout the pandemic. But this story is an example of how we work together as a strong team to make this happen. To hear their niece Sheila sobbing on the phone with joy and relief was absolutely priceless, and I will personally never forget the sense of team achievement and pride that we all had that night. We've all witnessed some really harrowing things in this last year that has tested our resilience and resolve. But on reflection, being part of this story has lifted the morale of the staff involved, and we still hear the buzz of the staff, don't we, Frankie, when they talk about this story. One of the key drivers in end-of-life care is to remember that we have one chance to get it right for our patients and their loved ones, and we certainly did get it right this time. Although there were issues that we encountered, everyone that was involved demonstrated a real can-do approach and a collective will to succeed for both Derek and Marion. The compassion and humanity was palpable, and this was an example of Team SFH at its absolute best. Derek and Marion are now resting in peace, and their funeral was on the 3rd of March. I truly believe that this lovely story will remain in the memories of all the staff that were involved and offer an uplifting example of the fabulous care that each and every one of us provide every day, even in the adverse conditions of a global pandemic. Next slide, please. Have the next slide, please. The final words go to Derek and Marion's family, so I'll leave you to read this letter of thanks. Thank you all for listening, and we would welcome your thoughts.
Thank you very much. I mean, that was a fantastic story, and I think I'd really like to thank you for not doing the easy thing, which would be to follow the letter of the guidance and the letter of the things, but actually to find a way of doing it safely and to providing the sort of compassion and the opportunity that you gave to this couple. So I mean, I just think absolutely brilliant and lovely to hear. So thank you very much, and if you can thank all those who are involved, because as you said right at the beginning, this was a big team effort from loads of different people. But you know, I think that shows that even in situations which are extremely difficult and where, you know, what we passed down in terms of what's required in the guidance, even they, you know, by thinking a bit laterally, by really caring, and by lots of people coming together, you can find a way of doing the right thing. So I'd just like to thank you really on behalf of the board very much. But any other comments or observations from people? I think everyone's dumbstruck by it. I think it's just I suppose I think it's really important in this that that we find there are a couple of people, and I'll come on to that, but it seems to me that there's something here about how you know, do something like this, take control, you know, get permission, give yourselves permission, etc. And I suppose there's something that maybe that's to reflect on. We've had one or two other examples. The whole homeless project was another thing where, you know, the reason that went so well is because they didn't seek permission too much, but they knew it was the right thing, and they worked very carefully and they thought very carefully, etc. And I'm not advocating anarchy, but it does seem to me that people who've got the drive, the commitment, and indeed the care to, you know, we need to find ways in our culture of allowing that to happen in lots of different places. And I think we do, but yours is just a fantastic example of that. But let me go and bring in one or two other people who've come through. So I'm just looking at I think Simon, were you first?
I don't think I was, Chairman, but I'm happy to go first.
Okay, and then I'll go back. Yeah. Okay. So Simon, if you go, then I'll go back to the beginning. Yeah. Thanks.
Yeah. An incredible story, heartbreaking and happy in both ways. So just sort of Francesca and Deb, so well led, and thank you so much. And I think it's also worth remembering the role that Ward 21 plays every single winter in this organisation. Ward 21 is an elective orthopaedic ward, but the colleagues on there look after a whole range of patients over winter, and they do an incredible job. So thank you to you both.
Thank you.
Claire.
Thanks very much, John. And I just want to say thank you to both of you and to all of the staff for your compassion. I think sometimes it's easy to just follow the rules and be in a comfortable zone. And what you did was amazing. Thank you.
Thank you.
Graham? I think you're on mute, Graham.
It will come off eventually.
Yeah.
Thank you. No, I just wanted to build a little bit on what you just said earlier on. I think this is a really superb example of outstanding care. And it also shows that, yes, we have to work to a set of rules and regulations, but there are occasions when you need to challenge that. And make something happen, and that's why I think we are what we are. And it's as a kind of example that we can show to the rest of the staff that, yeah, do think outside of the box from time to time, because this helps us move us to another level if we work in this particular kind of way. And really thank you very much for the story, and the more I hear it, the better I feel about it as well. So thank you very much.
Thank you. Manjeet?
Thank you. Likewise, you know, it really is. What I was going to say is, we talk about terms like friends and families test and things like that. This story, you know, powerful story, just makes it really real, doesn't it? In terms of, yes, of course, I would want my friends and families to be treated by this trust, and amazing people like yourselves. And so, you know, the team, thanks a lot for what you've done. And my question really was about, you know, when I talk about these words like improvement and friends and family, they're all management words. And if there was one piece of advice you would give to us as a board, what would it be about, you know, how we help improvement? Because you're the ones doing it on the front line.
Oh, that's a good question, Manjeet. I think having these opportunities to come to board and speak to you all as a collective, really, and you know, really tell you how it is on the front line. I mean, one of the things that, just to go back to John's original point about how we do this and how we think out of the box, for me as an employee of Sherwood and as a leader, it's the trust that's put into people with their roles that our leadership team give us, really. So they trust us to know that we're going to think about doing the right thing and ask the right questions at the right time, so that actually, you know, we're not gung-ho. We have got a crafted way of doing things and make sure that we do ask the right questions. And that's why so many people were involved that day. It was a really, really long day before that decision was made. And I think that's probably where my anxiety came, really, about, crikey, we're going to run out of time here to make this decision. But and the reality was that I think they had about 3 hours together, didn't they, Frankie, in the end? Yeah. I think Derek died first, and there were 3 hours together. And I can't tell you how absolutely ecstatic I was that I made that decision then, because I'd have been really kicking myself if I hadn't done it. But again, it was because we all kind of like metaphorically held hands and made this happen together. But I think it's that trust that we have between each other of us, and also from a leadership point of view, right from yourselves downwards. You know, you place your trust in your teams that are doing this every day. So I think that's, just carry on doing that, because I think that's really, really powerful.
Thank you. Emma?
Thank you. Thank you, Chair. I think, again, I just wanted to feed back how emotive and beautiful the story about Marion and Derek was. And I think what really struck me, and you picked up on it, is that you're trusting of human instinct, even when the science might not stack up. And I think that's so powerful. And that is about, you know, you feeling empowered to actually do the right thing for patients. And in hearing that is just wonderful. So, you know, the 65 years of marriage for Derek and Marion, and, you know, making those final moments happen. Yeah, I think it's remarkable. So just thank you so much to everyone. Real compassion and kindness. So yeah, thank you. Well done.
And Julie?
Thank you. I've heard this story already because I have the privilege of seeing it at Nursing and Midwifery Committee before, but it got me a second time. I just want to say a huge thank you to Deb and to Frankie. So Frankie is very new to post. She took over in wave 2 to support Ward 21. So just a big thank you to both of you. And I think if you were to ask Deb what she'd like for Christmas, she'd say some permanent end of life beds. So I'll leave you with that.
I was holding back, Julie, but thank you for putting that in there.
You take every opportunity. Well done. Well, I mean, I just think, you know, thank you very much for that. It was really uplifting, and huge admiration for what you've done. Absolutely brilliant, lovely. Thank you.
Thank you.
Thank you.
Okay, we're going to take a 10-minute break to give ourselves a rest from the screen and reflect on the last item. So if we could be back at our 10:50, time to get a coffee or whatever you need, that would be great. Okay, thank you. Okay, are you there, Suzanne? Can you open it up?
You're live now, Chair.
Yeah, no, I'm just trying to get rid of the public board will resume shortly slide.
That's gone.
Oh, it's not on my screen. Okay, oh, there it is. Yeah, lovely, thanks. Good. Okay, welcome back to the board. Single site single oversight performance framework. Paul, do you want to lead on this?
It will, yeah, very briefly. I'll hand straight over to my colleagues. This is the monthly performance report against the single oversight framework. We'll lead off with quality. Julie, are you going first?
Yes, thank you. So there's just 3 things to draw to your attention. You'll notice if you look at the C difficile numbers, at present, we are reporting 68 cases compared to 56 cases. We are a bit of an outlier in terms of trust around us because most people are under where they were this time last year. We've had a look at our data and it's become apparent to us that 6 of those cases are duplicates, so the same case has been reported twice. We've also had 5 cases where patients were tested shortly after the 48-hour window. It's quite likely that these are community onset C. diff cases, but because we sampled them late, they do go against our numbers. And then there are 10 patients that were sampled, even though they were here really as outpatient attendances and not truly inpatient. So there's some learning for us in terms of the reporting, and we continue our actions to reduce the incidence of C. diff as well. Moving on to hospital onset COVID-19. So we've seen a significant reduction this month, which is great news for us, and I think is mostly attributable to the rapid testing at the front door. Most of these 9 cases were related to an ongoing outbreak or cluster within the hospital that had oversight from NHSI and PHE as part of that protocol. We've again identified the timing of sampling, because if we don't sample patients before they've been in hospital for 7 days, they do become a hospital onset case, and we've had some where they were sampled on day 8. So we are monitoring our compliance with timely sampling as well. We continue to complete all of the RCAs, and we are implementing the national guidance around declaring serious incidents where patients who have hospital onset COVID and then go on to die have a full investigation. The final one to draw your attention to is the Dementia Assessment. So we remain well below our trajectory, but you'll see there is an a slight improvement this month, and that's because we've now widened the pool of registered professionals who can complete that assessment. So we approved for registered nurses who'd received training to complete this assessment, so we should see an improvement in that going forward. And I touched on the maternity FFT. Dave, I don't know if there's anything you want to add.
Thanks. The only thing I'd add to that, Julie, is just going back to the COVID-19 hospital associated deaths that we've now got a process and a group established to work through those. Obviously, there's a root cause analysis that goes on initially, as Julie suggested, and those patients are going through structured judgment case review processes, and we'll bring back those reports and that data through the quality committee if board is comfortable with that.
Okay, thank you. Any comments or questions from anybody? Barbara.
Thanks, Chair. Julie, I just wanted to...
Lost. So you'll have to repeat that, Barbara. We just lost you for a minute. Still can't hear you, sorry. Tell you what, we'll come back to Barbara in a minute, okay? Because we can't, I'll just tell her that.
Maybe turn your camera off, Barbara.
Apologies, I'm having really bad problems with my internet. Can you hear me now?
We can, yes.
I'm so sorry about this. I was just asking about the timeline for the nerve centre, for the dementia screening, you know, the implementation of the IT solution. You said in the paper that that was just about to happen. I just wondered if you've got a timeline, please, Julie.
Dave, are you able to answer that? Because I think you're closer to the nerve centre than I am.
Yes, to be honest, Barbara, this has been pushed significantly back. We've been rolling out other nerve centre upgrades that have had really quite significant importance during the COVID pandemic, such things as getting a COVID dashboard and all of those aspects. So it's been pushed significantly back. I think we still have some problems with the with ED and acute medicine using the nerve centre. We're certainly using it for the OBS, but in terms of recording and collecting that, we've got some issues there. So there will be quite a lot of training that needs to go in with that. So I think this will be back into probably towards the autumn of this year by the time it comes on stream. I don't think we've seen any marked reduction that we would perceive as an issue in terms of the care that we're getting. We still think that we get very appropriate referrals when we need to have the appropriate referrals, but in terms of capturing this and showing the data, which is exactly what you're asking, I think it will be delayed.
Okay, thank you for the update. Thanks.
Neil.
Yeah, thanks, John. Just wanted to ask Dave, can you give us any update on where we are on the HSMR reduction plan? I know there's a lot of work going on, but just wanted to understand when that's likely to start to yield results. And I do appreciate there's a delay in the Dr. Foster staff.
Thanks, Neil. We brought an update through board last month on that, and we've taken an update through Quality Committee, which is in today's papers, which in fact was a similar discussion to what we had at board. In terms of actually a date when you're going to see a reduction, we've seen a reduction from the HSMR. It has been coming down. What I wouldn't think the board need to take from that is that is a result of the work we've done. I think that is just the variation that we've seen. I think the original data timeline that Nigel gave board last month was around some immediate actions, which had a 3-month timeline. Longer actions had a 6 to 9 month timeline. So I think we will see the HSMR continue to be at this sort of level for the best part of I would think 12 months before we actually see any change in that.
Okay, and just a couple for me then. First of all, it seems to me on the C. diff that there's sort of two aspects. One is what do we actually do operationally and clinically, which I know you're looking at, but the second is we've clearly shot ourselves a bit in the foot here, haven't we? I mean, double counting patients, including outpatients in there. Is there any scope to adjust where there's been obvious problems in the counting, or is it once you've declared them, they're declared forever?
We've asked the CCG and they've sent us the rules back, which basically say they're declared. Right. So for the new financial year, Sally's putting in some measures to ensure we are reporting appropriately.
So we should be doing properly then. Okay, thank you for that. And just to mention the, I've had a summary report. I think the Ombudsman's office has sent out some sort of complaints framework or whatever else, which there was a summary report I saw. So I assume we'll pick that up and look at what the implications and lessons are for us in terms of both how we handle complaints, but also what the board needs to see, because I do think that one of the areas we have talked about in the past is about actually getting more patient input. I know we have the patient stories, etc., but some of those complaints I know is a very small aspect, but we have raised in the past that this is something we need to be thinking a bit more about. So I don't know what.
Yeah, we've got a draft patient and carer engagement strategy, and that is much more about engaging with patients when things don't go well and when things do actually go well as well. So we have an opportunity there, and the Quality Committee have had first sight of that. We're just making some adjustments, and I'm sure that will come through board with our action plan via the Quality Committee.
Okay, thank you for that, Jodie. Manjeet.
Thank you, John. Apologies, my question didn't go through earlier. My question was actually on dementia screening, and it was similar questions to previous ones, in that I just wanted to understand what are the key mitigations and what does that trajectory for improvement look like? Are we clear on that?
Yeah, so the issue here is that it was moved over onto the electronic assessment module, and the assessment module hasn't been rolled out at the front door, so within ED and EAU, where most of these assessments take place. So we do a paper audit as well to make sure that actually the assessments are taking place. So that paper audit does show good results, but it's not being transcribed onto Nerve Centre. So pre-COVID, we had somebody from the dementia team going around and transcribing it onto Nerve Centre. But because of COVID and reducing people going to the wards, we haven't been able to do that. So I feel assured that actually the assessment's taking place, but a lot of it is on paper. What we are asking now is our registered nurses across the ward areas to put that assessment on Nerve Centre, pending the rollout of Nerve Centre to our front door services to help improve compliance with that. And as Dave says, we're seeing consistent referral rates for onward review for patients identified with potential dementia. So we have assurance at that end as well. Is there anything you want to add, Dave?
Okay, thank you. It seems to me, I mean, generally very good. Just want to go back a little bit to the HMSR, because I think this is something which, for this trust in particular, it's something, and for those NEDs and others who've been around since the start of the journey, this is something. And I just wonder whether, if we're going to be seeing these HMSR numbers at the sort of level they are for the best part of the next year before we start to see, whether, I know we've got Nigel in helping, but whether there's any other assurance we can get either from Dr. Foster or others about, so because, you know, lots of good work and we're getting a lot of, you know, assurance from yourselves, etc. But if we are having these numbers, I think we probably need to be able to demonstrate, if the CQC or anyone comes knocking, I know they haven't, that actually we've, and I don't quite know what that means, but I mean, if you take the Ockenden report, I think you brought in UCL to look at our return on that, etc. And whether there's some external assurance the board can have in terms of safety and that side of things, because if we've done that, then it seems to me that even if it does take a year, we're in a position where we've got a good story to tell about what we do. But I'm not saying we don't at the moment, but that's a validated good story, if you like. I don't know, is that sort of do you think that's over the top, Dave, or do you think that's something we have to give some thought to?
So the board needs the assurance that the board needs, absolutely, and I think that's a helpful suggestion. I think if I just reflect us back to the last discussion we had when we brought the HSMR paper on board, we talked about the difficulties that not just this organisation has had with HSMR, but actually a number of other organisations that people around the trust board have been with. Associated with, and the longevity of that. So in terms of I think we need to be careful and saying we'll see a reduction in a year. I think we'll have a much better understanding as to whether there is really any problem in a year. And what I would like to be able to do in that period of time is say, whatever the number is saying, this is the evidence that suggests that our care is safe and good. And those are two different things. I think the Dr. Foster question is really interesting. Dr. Foster is not the only commercial company that is available to help us with this work. I think I would reflect and say that when we're getting outlying reports based on 3 patients, and then we have to do an enormous amount of work on that, that's quite distracting. And if I was being cynical, I could say that is in the company's interest for us to utilise them. And I was having a discussion with Elaine Jefferson yesterday about some of the work going on at SAF, and they are using a different company to Dr. Foster, which is interesting. The other aspect that I've got is I've put the team have put the raw mortality data into a simple number cruncher just to look at the baseline figures, and whilst there is some peaks and troughs, but the peaks are in winter, which you would anticipate, it is fairly flat. I think that does give us some assurance, but I'm very happy to take that what external assurance can we get. The idea of bringing Nigel in was external, but if the board doesn't feel as though that's providing the answer, or the timeline is too long, then I think I can take that away.
Yeah, I mean, I'm not sort of questioning any of the work. I just think, looking from a board's perspective, the board needs to be able to demonstrate it's done that, and so perhaps with Barbara and the Quality Committee, you could have a discussion about what you think might be appropriate and proportionate in terms of that request from the board. Is that all right? Thank you for that.
Of course.
Okay, Paul, back to you then.
Thanks. I'll hand straight over to Claire and Emma for People and Culture, if I may. Thank you.
Thank you.
Thank you, Paul. Thank you, Chair. So I'm Emma Challens, Director of Culture and Improvement, and the report is attached. So just want to highlight again just some key areas to provide assurance and awareness of our continued support as an organisation. Obviously the last 2, 3, 4 months has been quite challenging, and we're now moving into a period of ensuring that our colleagues feel supported, have time to rest and recuperate before kind of activity and response around recovery increases over the coming months. So much of the focus at the moment is around building better together. So actually, how do we support those colleagues who have been working and supporting key areas safely transition back to their areas of work in a compassionate and supportive way, ensuring that their well-being and time out is a key aspect of that. So we've been working together quite closely from across with the Chief Nurse, Julie Hogg, and medical colleagues with that transition for colleagues returning to areas, and some of that's involved highlighting, identifying our existing wellbeing support, and also some increased psychological support where it is needed and required. So very much around supporting the next steps, and particularly April as being an area of time out and reflection. And with that, we've also been focusing on recognition of colleagues and trying to do some further take further opportunities really just to recognise on an ongoing basis that the work and commitment of our colleagues, and some of that more recently has involved providing colleagues an additional day leave, and with the invitation really to use that as time out for your own well-being, and to take that time to reflect and rest. So that's something that we've communicated last week, and it's been received greatly, along with other things that we've got in train over the next 2 to 3 months around recognising colleagues and the team effort of Sherwood Forest, and looking at a celebratory event towards the end of June of that as well. And the other key thing that's already been mentioned is really proud in terms of obviously the trust getting the Trust of the Year, but also in terms of our staff survey results. And we've been engaging with the clinical divisions and corporate divisions over the last week or so, and ongoing over the next few weeks with regards how we can continually improve as an organisation. So what that means is, how do we sustain Sherwood being a great place to work and receive care, and how do we continue to improve? So we're identifying particularly focus areas for the next 12 months and working closely with divisions and teams. One around supporting colleagues to recover and respond, but also in terms of how we can improve in those areas where we think we can do better. So those are just some of the key things that I wanted to highlight. Thank you, Chair.
Thanks. Claire, do you want to say something, and then we'll open it up for questions?
Yeah, thanks, John. Thanks, Emma. So just a couple of points from me. In terms of overall sickness absence, that is reducing and coming back into line with what we would normally expect at or around this time of year. Still higher than normal, but actually there is a decrease. Some of the things that Emma touched on there that we've put in to support colleagues also include some dedicated psychological support, which has been aligned to the Occupational Health Service. We've had really good feedback, particularly from some of the frontline services within Sherwood around access to that, and it is being accessed, and we've offered group sessions and one-to-one sessions, and the uptake on the one-to-one sessions has been really good and encouraging, and we're really hopeful that that is enabling people to be able to stay at work when they wouldn't have maybe otherwise have been able to do so. So that's really positive for us. Occupational health activity overall is still higher than pre-COVID, but it has come down to about 1,300 referrals per month from about 2,000. Whilst that has an impact on the Occupational Health Service, and we have put additional resource in there to support that service, the encouraging thing is that colleagues are accessing support through occupational health, and we would want that to continue because it both enables the prevention of sickness absence and also supports the earlier return of people coming back to work. The final things from me are around mandatory training and appraisals, which are below under the expected performance. However, that was planned due to us stepping down some of that activity, although I do know that some people have maintained it where they've been able to do so, and for appraisals we do have a planned programme of getting that back up to the target by June. That's all from me, thank you.
Thanks. Any Manjeet, you've got a question, I think. Yeah.
Yes, thank you, John. I mean, firstly, I just wanted to say that with the appraisals and the mandatory training, I think considering the circumstances over the year, even though the target's red, the number we've got, I think it's pretty impressive. And my key question was around the occupational health, Claire. Have we got any analysis of the reason for some of the referrals? What they may be beyond our well-being type of referrals? I just wondered whether there was a breakdown at all. Thank you.
Yes, we have, and the increase specifically has been largely related to people's specific concerns around COVID, either directly for them or the presence of it in the community and people's shared households. That's been the main reason for the increase, along with increases around people experiencing psychological distress, which was why we've put in the specific interventions. And at the next People, Culture and Improvement Committee in May, we are doing a bit of a deep dive into all of that, which will give us a retrospective look and enable us to do hopefully some better forward planning around the support that we need to put in place for colleagues, and ensuring that colleagues that need the support are the ones that are actually accessing it. I think that's really important. So that will come through to that board committee in May.
Thank you.
Thank you, John. Can I just follow up?
Yeah, of course. Yeah.
Yeah, I was going to say, no, that's useful as assumed. I just wondered, because previously we saw that the MSK related sickness was high. I wondered whether there were other related referrals, but that's helpful. Thank you.
Just a couple of points for me. First of all, we've now had the planning guidance, which I'm sure will be talked about later for next year. And obviously in putting together the plans and the schedules, that means we ought to be in a position to try and make some judgments about how quickly we recover and how we balance that with the fact our staff need time to recover. So I think that will probably be an important part of the plan in that sense. And the new financial proposals that have also come out maybe signal, hopefully if we're optimistic, signal a recognition at national level of the need to get that balance right. And the second thing I think is, you know, I know there were discussions with staff governors, etc., coming to the day's leave, and that's good, and I know it's been welcome. I do think that part of this is also about saying thank you little and often. And so are there some other smaller scale events or smaller scale things that over the next little while we can use as an opportunity of that, because I'm sure staff will be grateful for an extra day, although I know some staff have really struggled just to take their current leave. But also I know that some of the other things that we do are really hugely appreciated, in some ways a little bit more personal. So I just sort of saying, hopefully we've given some thought to some of those sorts of things.
Yeah, thank you, Chair. Yes, we have. We've had more recent conversations over the last 2 to 4 weeks, really, with regards how do we do little and often, and some of that is kind of reigniting our stars of the month from a clinical, non-clinical perspective. Obviously, we've got some key professional recognition and awards which will run throughout the year. We've also got things happening at Easter, and we're also planning the recognition week that I highlighted towards the end of June. And then we're also doing some further work across all of our 3 sites with recognising the work of colleagues, really, in terms of Trust of the Year, but also our continued progression as an organisation. So yes, we have highlighted a number of recognition that we would do on a continuous basis. So I think you're absolutely right. It doesn't have to be a big bang. Actually, it just needs to have momentum. So thank you.
Okay. Thank you for that. Good. Okay, thank you. Paul, back to you.
Thanks, Chair. I'm straight over to Simon for timely care.
Thanks, Paul. Just a few sort of points to raise as an introduction to my bits. Emergency access, I think, remains very positive and strong. It's the last day of the financial year yesterday, and we will end the year at 94%. For the 4-hour wait, which given the year that the organisation and our colleagues have been through, is incredible performance from everyone. So well done to that. Obviously, it's Easter this weekend, and we have a plan in place to manage Easter, which involves 4 non-normal working days. Most of our winter capacity remains open during April. And that will help mitigate any risks we have over that Easter period. And I think we'll come on to later. There's going to be a lot of changes around the sort of expectations of waiting times and emergency care over the next 6 months, and it'll be a real change in landscape. So I think we've got a lot of work to do over the next 6 months to build on what we've achieved whilst the 4-hour wait has been around. And take it into another space. Cancer, I think we were outside of our predicted range in January. I think that was a bit expected, given January was the very peak of COVID inpatient levels, and surgery was a bit affected, both here and at Nottingham. So we have a lot of patients waiting at Nottingham. The average waits and the 85th percentile weights remain at sort of pre-pandemic levels. We expect that to improve in February when we report on that next month. I think notably, we reported last month that referrals were up by 20%, and that has continued. And that is going to continue a pressure on the cancer pathways. We've got the redesign work underway, which is led by Liz Gemmell, who's an upper GI surgeon here, and quite like to bring that to the board in July time to give an update on how that's progressing, if that's all right, Chairman. And then finally, on elective waiting lists, they're stable, but as we've previously reported, 10,000 more patients on them than pre-pandemic levels. Again, the planning guidance is prescriptive about activity levels that are expected to be seen over certainly the first half of 2021-22, but we continue to treat patients in line with clinical priority through theatres. During April, though, we're not expecting to see a large increase in our theatre activity at Kingsmill. That is a month, as Emma mentioned, which will be very focused on colleagues in critical care and in theatres and the services that have supported them, taking some annual leave, being able to access wellbeing support, and generally be able to rest and recover somewhat from the past 6 months or year. But from the end of April, we expect our theatres to be operating back at sort of October 2020 levels. So they're just the key points that I wanted to pick up on, Chairman, and happy to take any questions.
Okay, any comments, questions from people? Just one for me, which really goes back to Neil's earlier question on cancer. And you know, even before the pandemic, we were sort of not quite hitting the cancer levels. So I think I'm sure Claire will talk with other members of the board about how the board gets a focus on that over the recovery period, and some of those other issues. I think because Neil quite rightly raised that, and we know it's an area that we haven't reduced our activity as much as others, but even so, we're still struggling. But Neil, did you want to come in on that?
Yeah, thanks, Chair. Just one thing. Within the new planning guidance, there is a requirement, I believe, to get back to the 62-day RTT figure that we had in February 2020 within the next financial year. So that gives us the target that we need to aim for, and it'll be good to see a plan as to how we get to that. But I fully appreciate, Simon, that in January you did have the peak of the second wave or third wave, whatever, of COVID to deal with. So that's fully understandable.
Yeah, so we are, so just on that, so that level that we need to get back to if patients waiting over 62 days is 45, and as you'll be able to see in the information, it's currently over 100, so there is work to do on that, and I think more than happy to bring that back to board in terms of the plan to improve that back to those levels. I think really in the changing landscape of access standards, I really welcome the 62-day standard remaining. I think that's enormously positive, and it gives good focus to making sure that cancer pathways are timely, but also that it starts to be viewed at a system level as well, because as we previously reported, 50% of our patients move between Nottingham and Sherwood Forest, and we need to start to see those two services as one cancer service, not two separate cancer services.
You raised the point there, Simon, about some new measures evolving, or the measures changing, and I'm not sure how up to speed the board are with those. I have to say I'm not probably as up to speed as I need to be, so that might be something to think about, just how, I mean, I know in A&E the measures, how they're measured, etc., change, so it might be useful in some way to make sure the board are briefed on that and those changes. I know you've told us a bit in the past, but you know, we forget these things very quickly as Ned. So.
Of course. Some of it is on the planning guidance paper that's in the in private board today, but more than happy to do a more detailed briefing note for colleagues about what those changes are, and we'll be incorporating a lot of those changes into the SOF for the coming 6 months.
Yeah. Shirley, did you want to add anything to that?
Yeah, I was just going to basically say what Simon's just said. We are revising the SOF for next year, so it will include these, but we're revising all the targets, so that will be coming to a board session before we do it in June.
Yeah, no, I think that's good, because otherwise we'll be comparing apples and oranges by looking at this year and
absolutely.
Next year, okay, thank you very much. I haven't got any more questions on that, so that's great. So Paul, over to you and money, I think.
Okay, thanks, John. We call it best value care in the.
Okay, sorry.
In this report,
I stand corrected. I stand corrected.
So I'll report the money for the year to date to the end of February. As at the end of February for the financial year, we're reporting a deficit of £6.3 million against the available resources. That is actually £1.1 million better than that forecast that we provided to NHSI back in the plan submission in October. That outturn includes expenditure in total of nearly £367 million, of which 20 million is directly in response to the COVID pandemic. If we look at the forecast for the year that ended yesterday, I expect that to record a £9.6 million deficit, which is 400,000 adverse to plan. And what that includes are two aspects of spend which NHSI, our regulator, now deem to be allowable. That being the increase in annual leave creditor. That is the valuation of the amount of annual leave that our staff and colleagues are carrying forward. And also another allowable element, which is we have been unable to recover all expected non-NHS income. And so the allowable amount that NHSI consider on this to be about £4.1 million. And when we adjust our deficit for that, we actually come in at £3.7 million better than the plan we submitted. Vaccination costs are included in our report, but are netted off by assumed income via different methodologies for that. And that at the end of February, we've spent 4.3 million in respect of that. And we forecast at the end of March to have spent 7.4 million as more local vaccination centres that came on board during the February-March period. In respect of capital, we're on plan to deliver our planned programme and to meet the delivery on the additional resources that we've received in year. And in terms of cash, our payments, our cash holding at the end of February reflected the prepayment regime that was in place during February, and that has now ended, so cash holding at March will be reduced to near normal levels. To take any questions.
Okay. Neil, do you want to add anything to that?
I think just one point, thanks John. There is a deficit across the ICS expected for the end of the last financial year, and negotiations are ongoing to see whether that can be negotiated away, given that the deficit that's likely to be reported was less than it was forecast at back in the phase 3 plan. If that's not the case, then that deficit may well have an impact on the plan for 21-22, which we'll come back to when we consider the 21-22 plan.
Can I just update on that? I've had an email this morning confirming receipt of £10.3 million additional support for the system. So the scenario that Neil painted there won't happen. The Nottinghamshire ICS system will record a surplus against the submitted plan for the year that ended yesterday.
Okay, that's good news. Thanks, Paul. It's just that this is a very rapidly moving situation at the moment. Not surprisingly, I'm a couple of days out of date, so apologies.
No, well, that's good, and I'm glad that the threat of our board meeting to discuss the system deficit led to £10 million being given. So, no, well done on negotiating that, Paul. I know these things are not easy, so well done. It's very good. Okay, I think that's the end then of the soft, right? So thank you very much for that. I can't see any more questions, so let's move on. So data security protection toolkit submission.
Yes, that's me again on my notes. So what you've got in the pack is serving two purposes. It's a report from myself as the Senior Information Risk Owner for the Trust, and it's an annual report that I'm required to make to the board, and it also provides an update on the completion and compliance with the Data Security Protect Toolkit. And in regards to the toolkit, as an update to the paper, I can confirm that yesterday all 111 mandatory items are now evidenced and uploaded, and that is advance of the final submission date, which is actually the 30th of June. So we've met the requirements ahead of and submitted ahead of time, which is great news. And regards to my CSIRO report, it describes the arrangements we have in place relating to the security of information and actually compliance, how we comply with the relevant legislation. And just one thing to note, that there've been two incidents in the last year which are reportable to the the regulator, and who is called the Information Commissioner's Office. That's the regulator for these matters, and we reported 2 incidents. And we were asked to provide the appropriate assurance, which we did on time, submitted that with no action resulting from those. So I'm happy to take questions on the report.
So first of all, any comments or questions? Shirley, did you have something? Yep. No. Okay, thanks. Graham?
Thanks, John. Just really to say we look at this through audit committee as well, and we'll look at it again, but really to thank Jackie and the team for all the work they've done on this, because we've met the original time frame. We did have more time to do this, but she's actually to have delivered all of them by 31st of March is brilliant. It's superb performance.
Yeah, so yeah, no, that is really good. Thank Jackie and her team. Okay, so can I assume that then this is approved by the board?
Yeah, thanks, John, and Graham beat me to it, so I described it as my report, but it's a report that Jackie wrote on my behalf, and basically she and the team do all the work on this, so thank you very much to Jackie and the team.
Okay, thank you for that. So that's approved. The annual sign-off declarations of interest, Shirley?
Yeah, this is the annual report that comes to board as part of the year-end process. So this has been previously approved at audit committee, and as you know, audit committee do focus on this every time they meet. Unfortunately, the number of non-compliant has increased towards the end of the year, basically due to the number of new starters. But that's a process that we need to get our act together on going forward. So we will be starting in April to remind everybody to complete for this year, because obviously as from today we are on everybody's non-compliant, no doubt. So yeah, this is just the usual annual report. So John.
Thank you very much for that. Any comments? Yes, Graham. Graham?
Sorry, John, my machine didn't want to let me do anything for a second. Yeah, just really comment back again. We take a very close interest in this through auditors. Shirley and I both know. I think that the new starter bit has just highlighted a little bit of an issue for us, which I know we're hopefully going to be on top of to make sure in future, as part of that induction process, we ensure that all new starters, where it's relevant, have completed their declaration of interest, so we don't have this problem in the future. Also, we've not chased quite as hard as we might have done at during the latter part of this year to get everybody declaring, because of COVID and because of what's been happening. We're going to start with a vengeance in the new year, and those individuals that have not declared interest for more than 1 year in the last 3, we're going to say that if they don't declare very, very early on this year, we want them to come to audit committee and explain themselves. So together with all the other measures, I'm hoping that this will be even better performance during the course of next year.
Okay, thank you. So subject to that, I can't see any more questions, so can I ask us to approve and sign this off? Thank you.
Thank you.
Gender pay gap report, Claire.
Sorry, just needed to get the microphone on. So the gender pay gap report is here for assurance. It is we are required to publish the gender pay gap information annually, and the requirements are usually for the end of the financial year. This year the deadline has been extended, but we were in a position to report as of the 30th of March, so we've done that and published the information on our website. The report has been to the People, Culture and Improvement Committee, and they were assured that in terms of the publication of the information, that was compliant with the requirements of gender pay gap reporting. There has been a slight reduction in the gap between earnings for men and women within the trust, and the committee have asked for some further detail about what underpins that level of variance, and we'll report that back through in May. happy to take any questions, John.
Okay, any comments or questions on this? No. And so can I ask for that to be approved as well? Thank you. Application of the trust seal, Shirley?
Yeah, this is just to say that since we last met, the trust seal has been applied twice on the documents identified in the report and signed off by Richard and myself. That's just here for retrospective approval by the board, please, John.
Okay. So can I ask, I don't see any questions, so can we approve this as well? Thank you.
Thank you.
Ben, welcome. On the
afternoon, sorry, morning, John.
Green plan. So can I hand over to you?
Yeah, certainly. So I'm pleased to be able to report and present the green plan to the board for approval. It's been supported by Helena Clements as our sustainability director and also the executive team. A green plan is now mandated by the trust, by any trust, as part of the NHS standard contract, following the publication of the NHS Zero Carbon Commitment in October 2020. The plan in summary covers the plans that the trust has got around its energy emissions, mileage, waste and single-use plastics, and also touches on elements of sustainable procurement, which we've worked with the procurement team over. The policy aligns with the trust's strategic priorities around the promotion of local health, because there is a direct correlation between controlling our emissions and our impact on the local community, and that the health of our staff and patients and the population in which we serve. And that's also a strategic priority of the ICP. The plan is also being supported by the recruitment of a dedicated sustainability manager to drive through and focus around some of the objectives that we've laid out within the plan. But it should be noted that some of the ambitious plans that we've got will escalate the cost of future capital developments, such as the adoption of green technologies and such like, which we currently don't undertake. So there is going to be an impact, but that'll certainly be factored into our capital planning going forward. So I'm happy to take any questions, John.
Okay. Any comments, questions on this? Yeah, Simon.
Hi, Ben.
Hi, Simon.
Thanks for that. Just a quick question about. So I think the report rightly references the changes that the COVID pandemic has had, probably in terms of travel. So 40% of our patients are now in outpatients are seen non-face-to-face. And obviously we've got a number of colleagues across the organisation who are now working from home.
Yeah.
Are we able to quantify the impact that has?
Yeah, we can. Using benchmarks, we'd be able to do that. Yeah. Where, if I was able to do that, where would you like that presenting, Simon? Just to support the plan? Or? Well,
I mean, I'm just more thinking about this in terms of emissions, really, and obviously in terms of sort of traffic and stuff like that. Yeah. And I think in terms of where we're trying to get to, and the quantification of like our contribution to reduced emissions and all of those sort of things, those two items are a big sort of chunk, and they're a consequential chunk of a wider sort of approach. And I suppose it's part of the wider question about how do we determine the impact and what are the building blocks to that impact. So I think it's an important thing to try and quantify in terms of the environmental impact.
Yeah. I mean, it's been a step change. It's been helpful in terms of achieving some of that. So yeah, no, I'll look into that. Thanks, Simon.
Thank you. Barbara.
Thanks, Ben. It's quite a comprehensive plan in terms of covering quite a range of issues there. I just wondered, which of those do you think is going to be the most challenging for us as an organisation to achieve?
I think it's the procurement stuff. So we've done a lot with the states through the PFI provider around carbon emissions, and that's built into the PFI contract. So in a way, that avenue's exhausted. But it's about this sustainable procurement going forward, because even when we're procuring energy, there is a cost prohibiting to procure energy in a sustainable way. So we can buy cheaper prices per unit for non-green energy. And as we go forward around the SIP priorities and opportunities, we'll be under pressure to offset our commitment against green credentials and that of what's the cheapest rate. So I think going forward, it's going to be the procurement of some of this.
So basically the financial impact, the additional costs. Yeah. Okay, thank you. Thanks for clarifying.
Thank you. Paul.
Thank you. Thanks, Ben. Just a couple of things in response to Simon's point. Ben, I think there's a need for us to report our carbon footprint in the annual report each year. So maybe there's a home for a comment around the reduced carbon footprint of travel through 2021 there, and then just a general point, welcoming the strategy, not least because it ticks the statutory requirement box, but also it demonstrates our ambitions and which we discussed as a board and led to that appointment of Helena as the lead director. So I fully welcome it. Thank you.
Thank you.
Sorry, Graham, I missed you out. Graham?
That's quite all right, John. No problem at all. And he's sort of building on a little bit from Paul and the others. I think, first of all, Ben, really good report, really helpful, and shows a way forward. Two bits from me going forward. One of them is picking up on Simon's point and potentially wider. I think there are those wider things that we can potentially consider and work through, and Simon's elements was a really valid one. So how we incorporate those going forward to make a much stronger case, if you like, of what we're doing. And the second one, which is kind of picking up, which I totally agreed with your response to Barbara, in many ways the biggest challenge is this is going to cost money. So I think there's an exercise for us to do to understand what the potential additional cost in relation to delivering this strategy and this plan will be, so we can actually highlight that impact a little bit more. It's not saying we shouldn't be doing it, far from it, but it's just making sure we're able to show that.
Yeah, will do, Graham. Thank you.
Thank you. And the only question from me, I can't see any others, is a lot of this links, doesn't it, quite strongly, I've got Neil in a minute, quite strongly into the NHS as an anchor institution.
Yeah.
And I wonder how much discussion is there going on at a system level around some of these things?
Quite a lot, because the system's been given an allocate. It's not a lot of money, it's £10,000 by the centre to align each of the providers' green plans. So Marcus Pratt's leading that work as the estates lead for the ICS. So that, it's that we are aligning as a system around this, John.
Okay, thanks. Neil?
Just first of all, just to say thanks, Ben. I think that for you and Helena, I think that's a great plan, and look forward to it being implemented. I just wanted to comment on Simon's point there. I fully agree with trying to assess the impact of people working at home and therefore saving in the commuting costs. But the flip side of that is that working at home incurs additional energy costs for those that do it. If I look at the size of my gas bill for last winter, I can tell you that's definitely true. So I don't know whether you can adjust for some things like that, but it's not a one-way bet, really. I mean, I think that there's the offsets in terms of additional costs that are incurred for people that are working at home as well.
No, I think that's a good point, Neil. Yeah. Okay. So I think there are a couple of things coming out of that. Obviously, as you take it forward, one is the extra cost of this, and indeed how, as a board, we're keeping an eye on the delivery of this. And secondly, I think the system working better, which we'd be keen to see, not just in this area, but in other areas in terms of under the banner of the anchor institution.
Yeah.
I think those were the people touched on different aspects, but I think those people really warmly welcomed this. So thank you very much, Ben, for the work you're doing.
Thank you.
Thank you.
Thank you.
Okay, thanks for that. Shall we move on to the assurance from subcommittees? So Graham first, audit and assurance.
Thanks, John. I'll just pull the page up. A couple of bits we picked up on during the course of the meeting, but just to raise counter fraud, we've got a new revised framework for counter fraud coming in, and although it only really is implemented from April, we're going to be assessed on it for this current year. So there will be some elements which we won't be able to meet those standards because we weren't aware of them at the time. So it's just for everybody to be aware of that when they see it later on. Secondly, internal audit is progressing pretty well, but there are a few challenges. One of them in particular we need to make sure is the delivery of the work around the data quality framework, because that forms part of the head of internal audit opinion. So it's really important that that one's completed, and I know the trust is aware of that, but it's just sort of making the board aware that that's a key one to be done. I think realistically, yeah, I picked up on register of interest earlier, and just to report that we completed the annual report to board and approved that for submission to board. So that's pretty much everything I wanted to highlight, but any questions, happy to take them.
Any comments, questions on this? No. Okay, thank you very much, Graham. Finance Committee, Neil.
Yeah, thanks, John. Apologies, there's no written report. The committee met 2 days ago, so there wasn't really time to produce that. It was a pretty full meeting. A lot of the discussion was around the 21-22 planning. A couple of days before the committee met, the planning guidance was issued. And in very simple terms, it's just stay as we are. The block contract arrangements will stay in place for the first half, at least the first half of next year. And the targets are being set at ICS level with an expectation that the ICS will break even. A couple of adjustments on efficiency of 0.28% and an inflation adjustment of 0.5% with a couple of exceptions, but the break-even position is where we need to be targeting. At the moment, the ICS is predicting a deficit, quite a large deficit for the first half of next year. So there is work being carried out at the moment to eliminate that deficit by building a bridge from where we think we are on run rate to where we need to be. With the intention of the ICS submitting a plan, I think it's on the 6th of May, setting out what will hopefully by that stage be a break-even position. So the committee is going to be looking at the SFH part of that plan at its meeting at the end of April, and hopefully approving that so that it can then go forward to the regulator. In connection with that, the committee also looked at the FIP plans for next year. Work is ongoing now, and a number of projects have been identified which are expected at the moment to lead to savings of just over £5 million during the next financial year. The biggest part of that is the outpatient transformation, where we expect to be able to reduce appointments by probably in excess of 10,000 people, which will lead to savings, which will hopefully allow us to benefit from the new elective recovery fund. But we need to be mindful that it has to be done in a safe way, and we also need to be mindful that that plan in itself is going to be difficult to achieve, given the need for to increase elective work and the need for staff to get a break in the first half of the next, now the current financial year. The committee also reviewed the internal audit report on the integrity of the general ledger, and was significantly assured because the report provided significant assurance. There were just, I think, only 3 points where there was a risk. There was one medium risk relating to the authorisation of journals, which has now been corrected. So I think we took great assurance in the fact that the general ledger on which the information that we receive is based, it has good integrity, and that's quite important. And then finally, we considered the BAF and decided that we didn't want to recommend any changes at this stage. The financial position is still somewhat fluid, and until we have the plans for next year firmly established, it's difficult to see how the risk can be sensibly reduced. And then a few matters I won't go into. We talked about the period 11 monthly report, which Paul's referred to already. We looked at the procurement forward view, which sets out the contracts due for renewal in the next few months. There's nothing in the immediate future. And then we looked at the terms of reference and the work plan for the committee, which were both agreed. So that's really all I want to say, and I'll happily take any questions.
Thank you, Neil. Any comments, questions on that? You referred to the lot of discussion on the planning priorities and guidance for this coming year. When does the board, what are the timetable? I know the timetable is submit plans from 6th of May and whatever the final one is. What does the board need to see before those plans go in, and how are we going to manage that? I don't know whether any thought's been given to that yet.
I think at the moment, I don't know, well, if Paul wants to come in, do you want to go in first, Paul?
Yeah, thanks. I think we agreed at the last meeting, John, that we'd have a regular update in the board's confidential session each month. We'll use that, and as Neil suggested, the Finance Committee, the next meeting in April, will focus on our what would be a draft submission at that point, and go into it in some depth. So that's the process that we've got in place at the moment.
Can you just have some discussion then with Claire about, okay, the Finance Committee doing that, what does the board need to see? I'm particularly thinking about how we set this within the wider ICS, because where risk sits and acceptance of other parts of the system to accept responsibility for risk, etc., seems to me an important part of moving towards system working, and in which we're going to be increasingly dependent on others to do their share as they will be on us. So I think the board does some looking at this plan for next year with a sort of system hat on and saying, okay, what assurance does the board need? Not just about what it's doing, but about what other organisations' commitment to some of this is will be important. Quite how that plays out, I don't know, but I think that that's a dimension which in the past we haven't really had to think about so much.
Well, from what I recall of this planning guidance, the system allocations and the system elective recovery requirements are more or less identical to that than were in the phase 3 plan that we submitted back in October. That there's no significant shift of anything else to a system basis, but so we'll bear that in mind in terms of how we report that and how we report that both to Finance Committee and through to the board.
Yep. Okay.
I think also, John, a lot of the oversight will probably be in the ICS as we move through next year, and I think that there is a Finance Committee, well, an embryonic Finance Committee, shall I say, in the ICS, and once that starts to act, and once the boards of once the board of the ICS becomes established, I think the oversight will probably move towards the ICS with a view to some kind of statutory backing from April 2022.
Yeah, no, I'm sure that'll happen, but exactly how that works, I think, needs to be thought through, and also how we make sure we continue to discharge our statutory responsibilities to this organisation whilst also having a system statutory. I mean, this is an old chestnut which has been around, but it's now getting a bit real, isn't it, as we approach April 22, so we need to do some thinking about it, I think, is all I'm raising. Okay, well, thank you for that. Anything else? No. Quality Committee, Barbara.
Thanks, Chair. So I'm going to take the report as read. There are 3 issues that we wanted to escalate to the board today. We spent some time at the committee in a deep dive around maternity and gained a good assurance around all the work that's being done around that. A lot of that linked to the Ockenden report that you referenced earlier, John, indeed. Secondly, there was an extensive plan shared with us to address issues around anticoagulation therapy, and that links to a preventing future death determination that the coroner issued the trust last year. So picking up on the recommendations from that, but going wider. So really good work underway on that score. And the third is really a confirmation that we've now had that unfortunately, the trust has had the formal accreditation for our haematology service withdrawn. And just to remind board members, this is primarily because we've been unable to appoint a clinical director to that post, and that is a requirement, one of the criteria that's used. So whilst we've tried on several occasions to make that recruitment real, it's just not been feasible. And in fact, there's a general workforce shortage for this area of clinical staff. So sad, but not a surprise. Just to reassure that although it is, we have lost that accreditation, in terms of risk, clinical risk, it really is minimal. So they're the three things to raise to the board.
Yeah, thanks. Any comments on any of that or questions? Dave? Yeah.
Oh, Chair, thank you. Just could I just note that this isn't a whole haematology service accreditation that's been removed. It's the UCAS accreditation of the laboratory haematology service, just for the avoidance of doubt.
Okay. And I mean, do we have some sort of timescale for this? I know it's all linked up in recruitment and everything else, but and secondly, or if I know we don't have accreditation, does that make any difference to the operational delivery of the service from where we were when we did have accreditation? Do we have to stop doing some things or not?
Shall I take that, Barbara?
That'd be helpful, Dave.
In terms of the laboratory services, there is no question that the quality of the services is in any a difficult position, and there's no question that the UCAS have concerns about the functioning and the quality of the actual results that are coming out. So for our patients, it has no impact. This is purely, as Barbara was alluding to, around a requirement to have a laboratory director. In terms of the impact that this has, there are three main impacts. One is that we have to declare this to other regulators, which of course we have done, and we use this laboratory for part of our antenatal screening services. That's around thalassemia. It's a relatively well, it's a limited volume service, but for the thalassemia screening to continue, that needs to be accredited by various regulatory bodies. We've had confirmation that they note the removal of UCAS, but they don't plan to take any further action because the quality of the lab is not in any doubt. The second aspect is around external providers that use our laboratory in a commercial way. So that is primarily with Bulbra, who utilise us, and again we've notified Bulbra, but they've not informed us of any proposal to remove their services, again because of the quality of the service that they're getting is not in doubt. And the third aspect is around our research activity that goes through the laboratory. So the majority of new research trials require samples to be analysed in a UCAS accredited laboratory. And that may have some impact, but we are unaware just at the moment of what the real impact will be. In terms of the timelines, that's a much harder question. We are actively pursuing a number of different avenues to try and address this. Obviously, we're in significant discussion with our close neighbours and more distant neighbours about this, but haematology, as we've discussed many times, is a fragile service across the country, really.
Okay, thank you. Any other comments on the quality report? Okay, thank you. And finally to Manjeet on the People OD culture.
Thank you, John. John, if I can take the report as read, we've covered many of the items, but I particularly wanted to focus on the three areas. I mean, the first was the staff survey. As we can see, that was an excellent survey result, and also a lot of validation in terms of the impact of some of what we're doing under the strategies. We looked at the various areas and we decided that there was further focus in terms of assurance on the violence and aggression part, but also in terms of some of the variances in areas, the focus on engagement with staff networks and people particularly under the age of 21 and over the age of 66. They were particularly some of the variance areas we looked at in terms of the assurance last week. The second item, what I wanted to cover was the trust performance on the NHS People Plan. We received assurance on that, and again, what I'd like to say was the majority of the items were all completed, and where any weren't completed, they were amber on track. So we're all online for completing all our actions on the NHS People Plan, and we're going to use the next committee to use that to shape the people culture and improvement strategy. And then we also reviewed the BAF risk, and this time we did feel comfortable in recommending that this is reduced to level 16 now, with the progress on the various fronts as we have been discussing. So those are the key areas I wanted to cover today in terms of the assurance.
Okay, thank you. Any questions, comments on that? Okay, thank you very much then. So that's the reports from the subcommittees, and as Manjit said, we did touch on a number of those issues in the meeting as well. Outstanding service radiology.
Hello, my name is Sarah Sentence. I'm Radiography Services Manager for the Trust, and that covers all our modalities. So, for example, plain film, MRI, CT, ultrasound, breast unit, screening. So it's quite a large service. There's quite a lot of employees, and also a lot of demand. People may know that diagnostics is a massive area of demand at the moment, and the focus of the NHS, due to that difficulty in managing all that's requested of us. We have demand obviously in all areas. We have a 24-hour service for ED and inpatients. That includes CT and plain film. And we also run 12 hours a day, most days, in ultrasound, MRI, CT, and cover our breast screening services on a 3-year pathway. Following the lockdown, we found that we had thousands of routine patients that were waiting for when we stopped the services, when we couldn't run all of them. And we did manage to do all our cancer patients and all our urgents during lockdown, but the routines were put on hold. At the end of lockdown, we had thousands of requests that we needed to catch up on, and we started straight away. As soon as we knew that there was a chance that we could start our services up again, we opened up all our areas as much as we can, taking into account social distancing and cleaning, and really put a lot of effort into making sure that those patients weren't waiting too long for their requests. We gradually worked through them over the summer, and our recovery was extremely good, and that was the whole team who wanted those patients booking and the services to get back to some kind of normal. Our performance on the recovery was extremely good, and I think we were one of the first areas in the trust to reach the 99% DMO1, which is the 6-week diagnostic wait, which we achieved in ultrasound. And we started off with a 3,500 backlog and managed to get that down to, I think the backlog has been, only 7 patients have waited more than 6 weeks this month. So a lot of hard work went into that, because obviously, like everybody else, we're still dealing with COVID patients, still got red patients, still doing the cleaning, still doing the distancing, and this has taken a lot of planning and a lot of spreading out our work. So using our community sites, using Newark as a green site as much as we can, moving where our vans go, because obviously we use vans to help with capacity, and also we've had some help from NHS England with the use of a CT van. So a lot of work's gone into it, but it's worked really well, and we're really pleased with it. And I think that is obviously what lent us to winning the Clinical Team of the Year and the Staff Excellence Awards. Yeah, I think we've learned much better, like everybody, in a much better way to deal with COVID patients. I think at first we realised that we wanted this empty space, we wanted empty corridors, and I think now our cleaning is slicker. We've got dedicated areas for COVID patients to stay in that's separate to the others. We weren't ready for that last time quite in that way. We've got a good way of dealing with them. We put them on the end of the list if we can. We know how to book and make the best of getting our ITU patients round. So I think we have reorganised ourselves in a little bit of a different manner. We make sure that we've only got enough red patients for the space that we've got, so we mix our waiting list in the right way. I think going forward, I think knowing that we can do this and we can manage is a big step forward, but also knowing that this demand for us is growing, we have got a radiology strategy to look at the way forward, because we very much need more capacity, and we're also looking from some of the national drives from NHS England that we're expecting in the future, community diagnostic hubs, so that some of our elective patients don't have to come into the main hospital for their elective diagnostic imaging or other diagnostics, because this really is an acute area, you know, with our very sick patients, and actually moving the outpatients to an area outside of the main hospital, I think is the future, and that's what the government's looking for. So at the moment we are looking at community diagnostic hubs and moving some of our diagnostics outside, because then we wouldn't have the same issue in another pandemic. I think that's the way forward, really, and nationally that's supported. So yes, there is a lot of work going off in the background on that, but we were lucky to have community hospitals, sites that don't have those green sites to move their patients to. I have said, and I was pleased that our Staff Excellence Award was a team. It was a clinical team of the year. They've been a fantastic team, and everyone has worked immensely hard to make all areas work really well, particularly our clerical team, who with the booking and persuading patients to come, changing the lists at short notice, and the amount of patients that were sat on a waiting list waiting to be booked at the end of the time that we were closed for routines was like a mountain to climb, and they've done extremely well with that. But really I think it's the mentality, one, that it's a team and it's teamwork, it takes everybody to make that happen, and two, there was such a will to want to get through those waiting lists, and they wanted to do it, and they know how important, I think, as well, that diagnostics is in patient pathways. It's the main use now in a diagnosis of patients, and people don't get a diagnosis and don't get a treatment without their diagnostics first. So that's where we're at, and I think we have a really fantastic team, and that's why I was really pleased that we won that award as a team.
Sorry, I've been talking into a dead microphone. Apologies. Just in terms of communications to the wider organisation, a few things. The awards, I think the research in the MSK was some really good examples of some of the work that's going on. I thought the patient story, there were some extremely strong messages which came out of the story and out of the subsequent discussions, which I think it would be worth reflecting on. I think there are one or two themes coming through in the SOF, so rather than comment on some individual things, it's more about actually how do we make the transition, how do we move from where we are, how do we balance both COVID and restoring normal services, some things that are, you know, we don't yet have the answers, but we've got that. And then I thought the green strategy was the other one that we should reflect on, both in terms of what we're doing, but also the wider thing. So those are sort of half a dozen. I'm sure I've missed out some things in that, Lorna. Is there anything you particularly think offhand? I mean, you'll have a chance to add some stuff, I know, but is there anything you particularly think I've missed?
I thought it might be useful to talk about the planning guidance as well in relation to the SOF and bring it all into one thing. And the patient story, I'm hoping that we can turn that into a bit of a case study, both for internal and externally, for people to understand the kind of things that we do.
Great. Okay. All right, we've got a list there. I'm sure other people may want to, if you've got one or two other things missing, please say. so that's that. Any other business? I've got Claire and Tim. I don't mind who wants to go first. Claire, do you want to go and then Tim?
Okay. John, I know that you made your comments earlier on about moving on to your seconded role at Leicester, but on behalf of the whole board, I wanted to express our thanks for what you've done over the last 4 years, for your leadership, for your very calm and gentle approach, but very important way of leading this organisation. And I know that the support that you've given to the execs and particularly to Richard, he would want me to reiterate at this, which is your last public board, as you move over to Leicester, our thanks for everything that you've done. And as I step into your shoes, I hope that I can do it justice and make sure that I continue the fantastic work that you have done in making this an organisation which has certainly improved significantly over the last few years. And I know you said that you've been around for the good bit. Yeah, it has been a good bit over the last few years, but that's certainly because I think we've seen such superb leadership across the board. So thank you very much, John. And Leicester are very lucky to have you, particularly as I know that what you're going to take over to them will certainly improve the organisation and the service that patients receive across the area. So thank you.
Well, thank you, Claire. And all I can say really is that when you've got people who, like we have, who work in this organisation, it makes the job of people like myself much easier. Tim, did you want to? You also wanted to on any other business? Tim?
Can you hear me now?
Yeah, I can hear you now. Thanks,
Hi,
Tim. Yeah.
John, just to say is apologies that I didn't bring this to your attention earlier, but some of you may know I'm proud and privileged to be a deputy lieutenant, and we had a meeting this week with the Lord Lieutenant, and one of my responsibilities is to ensure that the Lord Lieutenant is aware of what happens on his patch and in the community. So I brought to his attention the progress that Sherwood have brought, have been in place, and the fact that we received the HSJ award. And he wanted me at the first opportunity, which is today, to bring to the attention of you as the chairman and everybody at Sherwood Forest Operations his congratulations, and that he's proud to be the Lord Lieutenant in Nottinghamshire, and the fact that what we've achieved in such a short period of time.
Thank you, Tim. That's really nice to hear that. So thank you for bringing that back, and thank you for all the kind messages. You've still got me for another week and a bit, but thank you very much for those kind messages. I'm sure your show will continue to go from strength to strength. With that, the next meeting is on the 6th of May. And so I declare the meeting closed. I don't know if we've got any questions. Robin, are you monitoring this from the public?
I'm monitoring, Chair. No, nothing from the public at the moment.
Nothing from the public. Okay, so with that, I'll call the meeting to a close. We've got a little bit of time. Should we start the private board at 1 o'clock? Sorry, Shirley, did you want to say something?
Yes, John, could you just formally move to the closed meeting, please, just so that we can record it in the minutes?
I have to do it in that way, yes. I have to read this out. So, in accordance with Section 1 of the Public Bodies Act 1960, resolve that the representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest.
Thank you.
Okay, that's all right. Thank you very much. So we'll start that at 1 o'clock, if that's right. Time for people to have a bit of a break from the screen.